We'll get started here in just a couple minutes. Give everybody a few minutes to come in. Good morning. How are you?
Good. How are you?
Good. All right, we are ready to go. Caitlin did good. Where is it?
She's like, I'm always.
Okay, I think we are ready. Good morning, everyone. Good morning, YouTube world. Oh, goodness. Couldn't get this to work. I don't know why that's not connecting. Good morning. It's not going to connect. I got to do it manually here. I'm saving up for one of those follow me camera mounts. They're super expensive, so I have to save my pennies a little bit more. All right. Did anybody have any questions on the homework reading? You had chapter 7. Anybody have any questions on the homework reading? All right, let me get your scores. If you did not do the reading or the test, just let me know. Just say pass. If you did the test, I'll get your scores from you. Kendra? Okay, Kendra, do you have any of the others done? Yeah. I need 2 through 6. Any of those that you have? Yeah. Okay. You can come back. Okay, that's fine. Brittany? Lashadra?
No. I got 6.
Okay, I'll take 6.
90.
Thank you. Sahar?
100.
Do you have 6 done for me?
Yep, 95.
95. Thank you. Korea? Chelsea?
Yeah, on my for the last ones I had 100.
Okay.
And for the 600 and then 95 and 7.
Thank you. Catherine? Jordan?
I think I didn't give you 6.
I need 5, 60, and 7.
All 3 of them I got 100.
Very good. Thank you.
Yeah.
Megan?
And 95.
Thank you. Tanaya?
90.
Tanaya, do you have 3, 5, and 6?
Yeah. 3 I got 100. 5 I got 100. And 6 I got 100.
Thank you. Aaliyah? Ricky?
5.
Mm-hmm.
I got 100. 6. I got 100. And 7. I got 100.
Thank you. Lori?
You need 5.
I need 5, 6, and 7.
They were all 100.
Thank you. Nadine? Jasmine?
For 7, I got 85.
Thank you. Jamie?
95.
Thank you. All right. Anybody have any questions?
Yeah, for 8, since this is the following is not a serious problem that may occur when using the restraints. I put, you know what, I think I put, no, I got to, when I corrected myself, I circled the correct answer, and then I'm trying to remember what answer I put. Yeah, I put down the.
Okay, so when we use restraints and restraints cause a patient to not be able to move around freely, that's going to cause a whole bunch of problems. The digestion is going to slow down, which can lead to constipation. The muscles may start to weaken and they can even shrink, called atrophy. The secretions in the lungs can harden and cause pneumonia. It can affect your brain, your attention, your ability to concentrate. So immobility has a whole lot of really, really negative effects. And we need to know that because in healthcare, we tend to want our patients to just stay in bed. It's easier for us, right? But is that best for the patient?
It's actually doing more harm than good.
That's exactly, it's doing more harm than good. And years ago, that's what we used to do. We'd confine everybody to bed. Nobody was up walking around. We didn't do that. That's just ridiculous. Well, then we found out that it leads to a whole bunch of other problems. So as CNAs, one of our biggest tasks is going to be to help our patients remain mobile. So we don't want them in bed. We want to get them up out of bed and into the chair. We want to walk them. We want to encourage them, even when they don't feel like it, that activity really is best for them and it'll prevent a lot of long-term complications. So when you're looking at understanding that, when you're looking at number 8, it says, this is for those of you following along at home, this is on page 187, right here. Which of the following is not a serious problem that may occur using restraints? Remember that not. That word not means that 3 of the answers are right. We want to find the one that is wrong, okay? And that can really kind of trip you up. But the way to do this is to kind of reword the question with the answer in it. So if I was looking at this question, this is what my mind is going to do, okay? Is an increased risk of dementia a serious problem that could occur with using restraints? Okay, we know it affects the brain, but maybe not dementia.
Because once they have it, they have it.
Right. So let's kind of put that as a maybe. We'll come back to that one. Are they at risk of suffocation if we use restraints? Well, sure, because if they wiggle down in bed and the restraint goes across their neck, we could kill them. So yeah, that one is a yes. Are they at risk for weakened muscles and bones if we use restraints? Well, we know that that's an effect of immobility, so that's a yes. And could they suffer from poor appetite and malnutrition if we use restraints? Well, yeah, because they're not sitting up properly. They're not getting, a lot of snacks because they're restrained. So that's a yes. So remember, we're looking for the no. Anytime you have not, we're looking for the no. And dementia, remember we said, yeah, it can affect the brain, but we'll come back to that one. Dementia is a disease process, not a symptom. So A would be the right answer. Good? Does that help you guys walk you through that? Any other questions on anything that you missed? Any other questions? Okay.
I have a question for number 1.
Yes.
It says don't take an oral temperature of the patient, and then it has the things. I chose D because I remember you saying that if you take the temperature, after they've gotten, worked up or anything, their pulse can get up and it'll change their body temperature.
Right, but it doesn't say due to activity. It just says a higher pulse rate. Let me explain to you why A is the right answer. And I know the book covers this, but they don't do a really great job on it. Okay. So oxygen, when we have oxygen on a patient, that oxygen usually goes through the nose. There's something called nasal cannula. 2 little prongs go into the nose, pumps oxygen in. Oxygen is cooler than room temperature, always cooler. Well, your nose and your mouth meet at the back. If I showed you a picture, your nose passages and your mouth passage meets at the back. So if we have colder oxygen going in the nose, that means it's going to kind of pool in the mouth as well. Since it's colder and we're taking an oral temperature, it's going to affect the temperature. Yeah. And unfortunately, the book does talk about that, but it doesn't really cover it very well. It doesn't tell you why. Yeah. We can only take an oral temperature if they're conscious. We never stick a thermometer in somebody's mouth if they're not conscious, because you can end up hurting them. We don't use oral on anyone under 6. And that's because if they're under 6, they may not understand. We don't bite down on this thing. It's not a lollipop. We're not going to suck on it, and all of those things can affect the temperature. And has an elevated heart rate. Well, yeah, that's going to play into it. But what makes that not the right answer is it doesn't end with due to activity. because we may have somebody that just has an elevated heart rate. They may have something called SVT, which is supraventricular tachycardia, just a fancy word for high pulse. And they may have a heart rate of 120 or 140. And we're going to give them medication and some treatments to kind of get that pulse rate down, but it doesn't keep us from taking an oral temperature. Now, if the pulse rate is high because they just did 50 laps around the nurse's station, that would be different. Okay. So when you're taking the written test, it's super important to remember that we don't, just like the care plan, we don't add anything to the answers. The answers are exactly what they are. So we don't want to add anything in that's not there. And we don't want to assume anything. Good morning. Just use the information they give you and nothing else. Because the minute you change something, it changes the entire question. Okay. All right. So let's review. I know, another review. But there's a lot of information in this class. Oh, hi, Carol. Hi, Miss. Morning. I'm not sure if you did answer me, but I have the blue homework book of the edition. Do I still need the yellow homework book? No, you don't. The yellow book is specifically for homework reading. It's going to go over a lot of information that I don't cover in class. Some of it we do, but some of it we don't. So it gives you a lot of kind of that background information that you need when you're taking the written. You can take the written without doing the homework reading, but it is going to make you a much better CNA if you do the reading. So it's not required. It's not required for you to tune in. Certainly, it's not required to take the test, but it would help you prepare for the test a little more effectively, especially if you don't already have that knowledge. Okay. So I want to go through and review what we've learned up to this point, because if you've been keeping track, we've covered a lot of skills. We've got about 12 skills under our belt now, and we're going to learn a couple more today. We've learned all of the principles, and we need to use these principles to apply them to the skills that we're about to learn. So we're going to take a really, really brief review, and we're going to speed through this, guys. We're going to do a really brief review of all of the principles and the skills that we've learned so far before we jump into the new skills. Okay. This is the last review you get. So the lessons that I do next week, we won't be reviewing this stuff. So keep this in mind, okay? If you want to review, a quick review of everything before you test, remember the beginning of class 6 is what you want to watch, okay? Because this will be our last review. All right, you guys ready? Mm-hmm. We perform the skill as directed on the
Care plan.
We follow the care plan, the whole care plan, and
Nothing but the care plan.
okay, while we're performing the care plan, what are we looking for?
Abnormalities.
Yeah, changes, pain, abnormality, basically anything we see, hear, smell, feel, or think. Remember, if you're thinking, somebody needs to know about it. Okay. And who do we report all of those observations to? The RN. Even if they don't really matter to you, even, if you realize something and you think, oh, well, that doesn't matter, it does. Because if you bring an observation to me, it may mean something to me that it doesn't to you. Does that make sense? Okay. So I'll give you a great example. There is a bacteria that causes a grape Kool-Aid smell. So if you walk in a room and there's no grape Kool-Aid laying around and you smell grape Kool-Aid, what should you do? Tell the RN. And yeah, I mean, that may not have dawned on you before. I just smell grape Kool-Aid, no big deal. Everything that you notice needs to be reported. Because if you come to me and say, hey, a grape Kool-Aid smell in that room, it's kind of weird, and there's no grape Kool-Aid around, as the nurse, I'm going to start immediately looking for some sort of an infection somewhere. and I'm going to get in touch with the doctor to order the tests that we need. And if we can head this off very quickly before it becomes a major issue, we might save this person's life just by you saying a couple of words to the nurse. So even if you don't think it matters, report it. Okay. Every skill starts with an opening. What does every opening start with? A knock. Once we've knocked, we don't have to wait for the come in. If you get one, great. If you don't, that's fine, unless the door is closed. Remember, there's things in life you can't unsee. Don't barge in a room. But for the test, you can just knock and enter. Once we enter, who are we going to greet? The patient. And how are we going to greet them?
By name.
By name. Very good. What do they need to know about us?
Our
Name and title. Okay, and the skill we're going to perform. And then what do we need to get from them? Permission. And once we get permission, we're going to close the, and we've touched that curtain, so we want to wash our hands, and then we can go get our supplies if we need them. But our big point here is don't touch resident until hands are clean. I'm going to tell you, there's some videos out there that hand the patient the call light before you go wash your hands. Is that appropriate? No. Why is that not appropriate? Yeah. The other thing is you're in the room. The whole purpose of the call light is to call you when you're not in the room. You're in the room. That makes no sense. So a lot of these videos are written and performed by people who don't understand nursing process. So be careful there.
I just finished the last test.
Okay.
It was 2 through 7, right?
I need, 2 through 7.
2, I got a 90. 3, I got a 90. 4 was 100. 5 was a 95. And to be completely honest, 6 and 7, I had to use my cheat sheet.
Okay.
They're hundreds.
Okay. All right. Okay. So once we've done our opening, we're going to evaluate if we need gloves. Remember, this is one of the big 4. It applies to every single skill we do. So how do we know? Should we just wear gloves for everything and not worry about it?
No.
Why?
You'll forget that you're wearing them.
Okay. You'll start touching stuff without your knowledge. And who does that put at risk? Yeah, it's not about you, is it?
No.
Okay. So when should we wear gloves?
Bodily fluids, personal skin, and non-intact skin.
Okay, body fluids, personal skin, non-intact skin. Good. What's the first thing those gloves should touch? Should you do all your supplies with gloves on?
No.
No. Okay, because we want to keep our gloves clean for the patient. Very good. And once we have used our gloves on the patient, now they're dirty. We've got to be we have to pay attention to what we're touching with those dirty gloves. And then can we just take those gloves off any old way? No.
Touch the skin with the gloves.
Okay, so glove can touch gloves, skin can touch skin. All right, good. All right, if we need supplies, we got to have a place to put them. So we're going to use a barrier. It provides what kind of a space for us? Clean, right, because our supplies are clean. All right. When should we get that barrier? Okay, after we wash our hands, before we get our supplies. Very good. Should you get your barrier at the same time you get your supplies? No, we're going to get the barrier before first. Very good. And what should those supplies not touch? Uniform. Yeah, or the floor. We're going to get to linen rules in just a minute. I'm going to turn the air on, guys, because I think I'm having a hot flash. Okay. Yeah, it is. It is. I know, Florida. If you don't like the cold weather, wait 5 minutes. All right. Sometimes we're going to need to use a privacy blanket. How do we know when a privacy blanket should be used? Uncovered or undressed. Very good. What is that privacy blanket there to do? There's 2 jobs it has. Okay, so privacy is in the name, but it's also for warmth as well. Should we pull the sheet down and leave them uncovered before we put the blanket on?
No.
Okay, so we're going to put the blanket on top and pull the sheet down underneath. That air did not come on. It just did. Okay. All right. And when we're putting that blanket on, what do we have to be careful not to do? Shake it or snap it. Yep. And at the end of the skill, when should we remove the blanket?
And after your gloves are off.
Okay, after your gloves are off. Yep. And you're going to pull the sheet up over the blanket. Very good. So let's go on to linen rules, because sometimes we're going to need to use some linens, especially for washing rules and for bed making skills. So what can linens not touch? Uniform and floor. It doesn't matter whether the linens are clean or dirty. They can't go on the floor, right? What can we not do with linens, just like privacy blanket?
Snap or shake.
Snap or shake, right? Clean rolls toward,
Dirty rolls away.
yeah, clean rolls toward you, dirty rolls away. And if we don't use a supply, what do we do with it? Put it in the hamper. We don't leave it there for later, because anything out of our sight can't be considered clean. All right. If we have to move the patient around in bed, there's a special way we're going to do that. We don't have what in all settings? What are we not allowed to use without a doctor's order? Yeah, restraints or side rails, because side rails are a restraint. So if we're going to move a patient and we don't have side rails, where do they have to be after the turn? Safe zone in the middle, right. And which way should they be facing? Toward us or away from us? So in order to make that work, in order to make that happen, there's a step we have to take before we turn the patient so they end in the middle. What are we going to do? Scoot toward us and then roll away. Good? All right. We have quite a few washing skills. We're going to learn one today as well. What do we not put in the basin? Soap. Basins are no soap zones. If we're going to get water, we have to touch the faucet to turn it on. What do we need? Paper towel. Okay. We're going to check the water. What should it feel? Who else is going to check it? Patient. If we're going to wash a wet body opening, eyes, nose, mouth, genitals, rectal area, wound, rashes, sores, or incisions, we need a special, we're going to use gloves, but we need a special process. The leaves method. Very good. Very good. Whatever we wash, whatever we rinse, we dry. And we're going to be careful not to get our surface wet. If it does get wet, address it. If we're going to put lotion on, what do we do before? What do we do after? Okay. If we use something to hold water, that means we got to clean that something with basin cleaning processes. This is all done the same way. Doesn't matter what the basin is. Guys, simplify, rinse, dry, store. That's what we're doing here. But after you rinse it, set it down and pick it up with a paper towel. That way, if you do disinfect it out there in the clinical world, you're not touching it while you're disinfecting it. Set it down, spray it, paper towel to pick it up.
The leaves method is if you wash it, rinse it.
No, the leaves method was when we took our washcloth. Let me go through this again real quick. And you're going to see this again. We're going to use it again today. But we have a washcloth, fold it in half and in half again. And we put it in our hand in a diamond shape with the free edges up. Tuck the two sides in. And now we have an area to clean with. One leaf. We fold that leaf over. Good morning. We use a second leaf on another area. Fold that leaf over. Use the third leaf on another area. Fold that leaf over. Use the fourth leaf on another area. Fold that leaf over. And you can use the back side as well, which we're going to do today. Okay. So it's each leaf of the washcloth. That's why we call it the leaves method. Okay. So rinse, dry, store. Easy. But if we're going to store it, we have to open the drawer and our hands are not clean. So we're going to use a paper towel to store. Good? All right. And then we learned shoe rule. Oh, I don't have shoe rules on there. Okay. We're going to get back to shoe rules in a minute. Then at the end of every skill, we're going to do the closing. So the closing, there's 6 steps and the order doesn't matter. Can somebody give me one of those steps? They all start with C. Comfort. We got to ask if they're comfortable. Clean environment, clean and safe. Call light. Okay, what's that?
Document if needed.
Okay, we're going to get to that in a minute.
Permission. Wait, not permission.
Okay, so address preferences. Yep. So, yep. Open the curtain. Okay, so we're going to do all of those things, and it's going to sound like this. Thank you very much, Miss Jones. My name. Thank you very much, Miss Jones. Is there anything else that you need? Are you comfortable? Your environment is clean, bed's in a low position. Here's your call light. Open the curtain, and then I'm going to go. Yeah, I got to get those cooties off. Go ahead. I got to get those cooties off. Oh, yeah.
Okay, I was just wondering.
You can grab it. I got to get those cooties off of my hands. And once I've done that, then I can chart if I need to. But if I chart, I've touched the pen in the documentation sheet, and our standard is to end skill with. So if I chart, what do I need to do? Wash hands again. Good? So those are all the principles. We'll come back to shoe rules in a minute because we're going to use that on our first skill. So now let's review the skills that we've learned very briefly. This is going all the way back to the first week of class, which I know doesn't sound like it was that long ago, but it really was. You've got a lot of information in that time. So let's look at the pulse. What are we going to support? The wrist, right. A pulse is always reported over what time period? 1 full minute. Now, we might be able to shortcut it and count for 15 seconds and multiply that by 4, but how do we know which method to use? The care plan. That's right. So we're always going to follow the care plan. What is our normal pulse rate? 60 to 100. And what area of our fingers should we use? The flat part or the tips? The tips. Where is the pulse located? Thumb side. Way down here? Where? On the top, at the bendy part. Very good. And for the evaluators to count with us so they get the same reading we do, what do we need to announce? Start and stop. And this is in Florida, this is a skill that we have to perform with how many evaluators? 2. So you're going to do it twice. Since we counted something, what are we going to do with that reading? Document it. Don't forget to document. All right. We also learned dressing a resident. What are we going to ask the patient if we're dressing them? What they want to wear. Remember, you can make suggestions if you need to. When do you want to get that clothing? Before you undress them. Why? Okay, minimize exposure. Very good. When we're lifting an extremity to dress it, how do we lift it? From above? From below. And where do we want to support? At the joints. Very good. Very good. We remember how to do this using USA First. What does USA First mean? Okay, undress strong arm first. And then we're going to dress the weak arm first. Okay. We don't want to overextend or force movement. You don't want to break.
I couldn't figure out the word.
Yeah, you don't want to break the leg. Just remember that. Don't break the ankle. Okay, don't break the ankle. Yeah. Yeah. Good news is they're dressed well. Bad news is I broke the ankle. Sorry. Yeah. But they look good.
Observations twice. The first time, but then after the second time, do you wash your hands for the second time?
Yes.
Okay.
Yes.
For the pulse, you try
See,
once.
for me,
You wash your hands because you touch the pen, and then you go to touch them again for
Right.
the second time.
right. So for me, I would prefer that you do the entire skill twice.
But I know they want their Mai Tai, so I don't know if I
That's
just,
right.
If I just say I would wash my hands.
And document. They're going to let you document just so you don't have to
Do I
remember
have
it.
to go wash my hands in the
If it's not your first
For the
skill.
first one,
UN.
you're going to say, okay, so for the first, let me go back. Pulse, 2 evaluators. We did our opening, we washed our hands, we counted with evaluator number 1. Normally, we would do our closing, wash our hands, document, wash our hands. That's how we would normally do it. But the evaluators, where do they want to be? Yeah. So they're going to shortcut this for you, and they're going to say you can just write it. Okay, so you would just write it down. And you don't have to say you would wash your hands. I would. just so they know. And then you're going to count with evaluator number 2. After you count with evaluator number 2, you're going to do your closing, wash your hands, document, wash your hands. Now, the reason that I'm saying it that way, if you go to page 24, we're going to come back to this in just a second, or 25. Go to page 25 for me real quick. In the middle of the page, you see the 3 care plans? Okay, the first 2, what skill do they start with?
Measure and record pulse.
Yeah, measure and record pulse. So that's your first skill. Remember, for your first skill, you have to really wash your hands. So they're going to let you skip that, but you're really going to wash your hands at the end. Okay. When you're doing these skills, you have to do them in the order listed. Have to do them in the order listed. All right. So USA first means undress strong arm first, dress weak arm first. We're not going to overextend or force movement. Remember, don't break the ankle. What do we want to adjust before we leave?
Socks
Okay, socks. How should the socks be?
over the toes.
Okay, so the seam over the toes. What about the buttons or
Should
snaps?
Yeah.
Make sure they're aligned. What about the pants?
Make sure
Over waist.
Yep. So we're going to adjust all clothing for neatness. Okay. They are looking. They are looking. That is a checkpoint. So don't ignore it. If you look at the patient and the snaps aren't adjusted right, don't ignore it. They do see it. Trust me, this is their job. They are very, very good. This is all they do all day long. They are very, very good at this. There isn't a thing you're going to do that they're not going to see. So don't fool yourself thinking, oh, they didn't see that. They didn't notice it. Oh, they did. They did.
Are we actually gonna dress someone?
A mannequin. Yes, you're going to dress a mannequin. And we are going to ask the mannequin, what do you want to wear? The evaluator is going to describe an outfit.
So since we are dressing a mannequin, and I know like you're gonna have one weak arm, what do you do with the other arm? Like,
You're just going to dress it normally. And
Okay.
the other arm can move as, you know, as you wish.
okay.
So you can ask the resident, can you extend your arm into the sleeve? And you're just going to help the mannequin extend their arm into the sleeve. Like dressing a Barbie doll. All right. Where do we put all of the soiled items? In the hamper. Remember, they don't go on the floor. And where do we want to put the call light for this one? Stronger hand. Very important. Hand and nail care. If we keep nails clean and filed, we never have to trim them. That's the reason for doing hand and nail care. And if we're going to move something, we always have to lift from, below. That's right. And you're going to provide support. We're going to soak the hand in water. Whatever we wash, we
Rinse.
whatever we rinse, we
Dry.
dry. Yeah, do you guys see how all of this stuff just works the same way? Okay. We're going to put the hand on the towel, though, when we go to do the nails and lotion and all of that. So don't just have it on the barrier. Make sure it's on a softer surface like the towel. We're going to clean under the nails. And which end of the orange stick do we want to use? The pointy end or the slanted? Slanted. We're going to when we clean, what do we do before we go to the next nail? Wipe it off. That's right. We're going to file those nails to keep them at a manageable length. But how do we file? One direction toward the center. And we'll always apply lotion last. When we apply lotion, what do we do first? What do we do after? Yeah. Yep. All right. Making an occupied bed. This means we're changing the bottom sheet a half at a time. Okay. So half of the bed at a time. The patient, should they be on their back? You want the smallest footprint. So how do we need them to be? On their side to take up less of the sheet. So if we're turning somebody on their side, what does that mean? Yeah, you got to have them scoot towards you so that when they're on their side, they're in the middle. So clean rolls, dirty rolls away. Should the patient ever be on a bare mattress? Okay, so we're going to take that dirty bottom sheet, roll it toward the patient, tuck it Take the clean top or the clean bottom sheet, secure the corners, roll it toward us. Tuck that underneath the dirty. Yep, make sure there's no wrinkles.
Oh yeah, what if the patient refuses to roll to the side to roll on the side of the bed? Like,
Yeah, so what the question is, what if the patient refuses either the skill or a step in the skill? Okay, so it doesn't matter what they're refusing. Who should we notify?
The nurse.
The nurse. So here's the problem. If they're taking up a significant part of the bed, we're not going to really be able to do this without leaving wrinkles or injuring them, because now we're trying to shove our hands all the way under the patient, which could injure them. So if they refuse to turn on their side, can we do this skill?
No.
Who do we tell?
The nurse.
The nurse. Let me tell you a story about that real quick. So time out real quick. When I was a brand new baby nurse, didn't know anything. I was working at a nursing home, and we had a patient that was very, very, very heavy, over 400 pounds in the bed, and I was trying to put a chucks under her, and she wasn't able to roll effectively on her own. So I was literally trying to push the chucks under her. I had gloves on, right? Because I'm never going to put my hands under a patient's bottom. There's a whole unknown there. So I was going to wear gloves, right? We don't like unknown. But as I was doing that, as I was tucking this, I had on my engagement. Well, this hand, I had on my engagement ring. And I had the patient kind of leaning up on their side a little bit so I could tuck. Well, she rolled back on top of my arms at well over 400 pounds. I had to pull my hands out. When I did, that ring gouged under her, broke the glove open. It was a whole thing. But she ended up with a very significant, deep scratch that we then had to do wound care on. And so we have to be really, really careful when we're working with patients that can't turn on their own, because the risk of injury there is pretty high. And I have remembered that throughout my entire career. Remember, I've been a nurse for 35 years, and it made that much of an impact on me. So we've got to think about the safety of our patients above all. Does that help?
Did you get in like serious trouble because there was an accident?
No, it wasn't trouble. I went directly to my supervisor. Remember, I was a baby nurse. Went directly to my supervisor, explained what happened. We called the doctor, called the family, got wound care orders, all of that. We followed protocol. I apologized to the patient profusely, because how horrible is that? I'm there to help, not hurt. But the DON, or I'm sorry, the ADON at that facility knew I was a baby nurse, took me aside. Now the nurses eat their young. It's horrible out there now. But took me aside and said, okay, what can we learn from this? What can we learn? And yeah, so my solution was I probably should not be wearing rings in a clinical setting. So I went and got a chain, and I put my rings on a chain. It was very long, tucked it inside my uniform. And that's where my ring lived. Sure. Back then they didn't have the silicone rings. Yeah. So yeah, you can. If you notice here, I am married. I do have rings. I have bracelets. I have all kinds of shiny pretties. But when I'm working, you don't see them. Why? Why? Okay, it could be a hazard. I could put one of you guys in jeopardy by demonstrating these skills. I don't want to do that. My vanity is not worth that. But here's the other problem. At home, I cook. If I've got rings on in a clinical setting, they're going to pick up pathogens, and it doesn't matter how much time I spend at that sink. Those rings are still going to harbor pathogens. Do I want those pathogens in my kitchen? No. So I don't wear jewelry in a clinical setting, period. That's me. That's not a rule. You don't have to follow it. But for me and my risk assessment, that's the decision I made.
What about a watch?
Watches I do wear.
And they're flat.
Yeah, I do wear, but I try to clean them.
Yeah.
Like this, the band can actually be washed, and the bottom part of this, I can wipe off with a lens cleaner. So I do wipe my watch down at least once or twice a day. So you can. Yeah. Back in the day, I used to wear a waterproof watch. So when I was washing my hands, the watch got washed as well. All right. So once we have the sheet under the patient, we're going to turn them on their back, go to the other side of the bed, repeat the whole process to get that bottom sheet changed out. Once we have that bottom sheet, the dirty one, off the bed, where does it go? In linens. Can it go on the floor? Okay. Then we're going to put the top sheet on, make hospital corners, just get those edges of the sheet under the mattress. Take your privacy blanket off and change the pillowcase out. Which direction should the pillowcase face?
Away from the door.
Away from the door. Very good. All right. Turning a patient onto their side. If they can't scoot themselves, we'll scoot them using whatever method is appropriate. You can use segment. You can use a draw sheet. You can use a slide sheet. Care plan will indicate if you need them to. Or if the patient can, you can just ask them, will you scoot toward me? And for the test, that's what we're going to do. We're going to ask them, scoot toward me. But once we have them on the side of the bed, we've got to position them for turning. Furthest arm goes. Closest arm goes. Closest knee bends, foot flat on the, and furthest knee gets angled out. You get them in that position, turning them becomes a breeze. If you get them in that position before you scoot them towards you, though, it's not going to help you a bit. Remember, you always have to scoot them toward you first. Once you get them on their side, how are we going to keep them there? Where do our pillows go? The leg?
And under the arm.
Just the one behind the head. Good. Okay. The way I remember that is when you get somebody laying on their side like this, it's kind of a blah, you know, that just kind of blah. B-L-A-H. Back, leg, arm, head. Okay. Blah position. When I'm feeling blah, that's the position I get into, curled up on my side. Blah position. Back, leg, arm, head. Good. All right. Foot care, just like hand and nail care, a little lower, and we're not doing the nails. So we're going to soak the foot. We're going to take it out of the basin. Are we going to put it right on the barrier? What do we put it on? Towel. We're going to wash the foot. We'll put it back in the basin to rinse. We take it out to dry. And we're going to wash, rinse, and dry everywhere. Where do we not put lotion?
In between the toes.
Okay, why are you there?
Warm, dark, and moist.
Okay, so yeah, that's for lotion. Yeah, we don't want lotion there. Why are you doing foot care? To look at the foot. Yeah, so for the test, what do you need to be saying?
I'm looking for observations.
Yeah, I'm looking at the foot. That's, you know, I'm making observations. I don't see any red areas. Your skin looks into, I don't care what you say. Let them know that you know why you're there. Otherwise, they think you're just washing. They got to know why. It's an important part of foot care. And then we're going to put the shoe and sock back on. Make sure that sock is put on correctly. Okay. Mouth care, brushing teeth. Guys, you all know how to brush teeth, but your patient is laying down. Got to sit them up. Since they're in bed, when they spit, it's going to go everywhere. How do we protect their clothing? Towel. What do we do with the toothbrush before we put toothpaste on it? Okay, you're going to brush the top, the bottom, the front, the back, and the tongue. You're going to let them rinse once, twice. Yeah, whatever they need. So not a lot of toothpaste. And then you're just going to clean your basin like you clean everything else. Okay. How do we leave this patient? How should they look?
Comfortable and presentable.
Okay. Dry. Dry. Yeah. And it's funny because with mouth care, that step gets missed a lot. Don't forget to look at your patient while you're doing these skills. You're going to focus on you. It's testing day. It's all about you and your mind. Don't forget to look at the patient, because who should it be about?
The patient.
Yeah, if you can make that flip, man, you will do fantastic for the test. Just remember, it's all about the patient. All right, respirations. What can we not tell them?
That we're counting.
Yeah, we're counting their breathing. Absolutely. In and out counts as
One.
How long do we count for? Yep. Normally 1 full minute, or as long as care plan says. If it doesn't say, we can do a shortcut, but as long as the care plan says. That could be a written test question. In fact, it probably will be a written test question. How long do you count respirations? As long as the care plan says. All right. When we're doing this, because the evaluators are counting with us, what do they need to know? When we start and when we stop. And since we counted something, what do we have to do at the end? Document. Very good. Range of motion. Remember that CNAs do exercises to retain function. We're not trying to make anything better here. We're just trying to maintain what we've already got. So if we're going to lift an extremity, we always support under the joints and we lift from below. Okay. So up, down. Anybody remember what that is called? Okay. Flexion extension is up, down.
And then adduction and abduction is side to side.
Okay, adduction is side to side. And what's around? Rotation. The earth rotates around. Yeah. Okay. And how many repetitions do we do?
3.
However the care plan says.
Yeah, however many the care plan says. Very good. All right, denture care, just like mouth care with an extra step. Okay, because remember with denture care, we do mouth care as well. So when we're cleaning the dentures, what kind of water do we want to use? Cold. Yeah, cool water. How do we prevent the dentures from breaking? Washcloth on the bottom of the sink. Do we need gloves to touch dentures? Yes. Okay, do we want to put the denture brush directly on the side of the sink?
No.
Where can we put it? In the basin. Good. That denture brush, we're going to treat just like a toothbrush. So what do we do before we put toothpaste on it? Wet it. Yep. Very good. Very good. And then once we're done with cleaning the dentures, where do they go?
In the denture case.
Okay. In the denture case. What do they? Yep. What do they? They're very good. Water. Right. Because our care plan tells us to clean the dentures with toothpaste. Yep. So we're going to put it in a cup of water, and then you can just bring it over and put it on the bedside table. But what do you want to put under that cup? A napkin. And then you're just going to do mouth care like you do mouth care. So remember, denture care is mouth care with an extra step. When we ambulate, boy, we learned a lot, guys. When we ambulate a patient, ambulate is fancy word for walk. Yeah. Lift them, walk them. When do we want to put the gait belt on? When they're sitting or after they stand? Sitting. All right. Where does the gait belt go? Around the patient's waist. Very good. Does it go over or under their clothing? Over the clothing. And when you stand in front of a patient to lift them, do you stand knee to knee, toe to toe?
No.
At an angle, at an oblique angle. Where do we want to hold that gait belt? At the front? Sides or back. Very good. Awesome job. How far do we walk this patient?
Whatever the care plan says.
Ours care plan says. Remember, it's a return trip. So if it says 10 steps, you're going to go 5 steps and 5 back. What do you want to observe for before you stand the patient up? Okay. Yeah. We're going to do that you can do that anytime, but specifically after we stand. But do we want to see if there's anything that might be in our way? Look for obstacles.
And make sure their feet are on the floor.
And we're gonna, very good. I didn't even ask about that. Good. You want to make sure their feet are flat on the floor. Very good. Awesome. See, now you guys are bringing up stuff that I'm forgetting about. Good job. All right. When we pull that gait belt off, how do we not want to do that?
Rub it across them.
Okay. If we're going to seat them in a chair,
Make sure their legs feel the chair before they sit down.
okay, good. And we always want to make them a partner. So what do we need to do before we lift them?
Have them put
1,
their
2, 3.
hands on the shoulders.
Okay, hands on shoulders and
1, 2, 3.
1, 2, 3. Good. Look at that. Partial bed bath. Oh, the longest skill. This is a monster skill. Partial bed bath. Whatever we wash,
Rinse.
whatever rinse we.
Dry.
How do we know, since it's partial, that means we're not doing the whole body. How do we know what parts of the body? Care plan. Okay. All right. And for our purposes for the test, we can simplify this face to waist, front and back. How many arms?
One arm.
One, because that's what the care plan said. Okay, which area are we gonna watch first? Face. Do we put soap on our washcloth? No soap. Okay. What method do we need on the face? Why?
Open holes.
Holes. Very good. And do we want drippy wet washcloths?
No.
Do we want uncontrolled washcloths? No floppy corners? No drippy? Okay. All right. If we're going to lift the arm to clean the bottom of the arm and the armpit, what do we need to do? Support it. Okay. And how are we lifting? Below. If the water gets cold, what do we do? If it gets soapy, what do we do? So we need to be aware of that. If we're going to turn them on their back, what do we have to do first? Or on their side, what do we have to do first? Scoot and then roll. Okay. And we're going to give a little back rub with lotion. Is this massage therapy?
No, it's the circulation.
Okay, so just 3 little trips from waist to shoulders and little circles. And then what do we want to do with that lotion?
Wipe off the excess.
Wipe off the excess. Okay. All right. Remember to remove that towel that's under the patient at the end of the skill too. Don't leave them on a towel. If they go to roll over and there's a towel underneath them, that towel's going to bunch up and that creates wrinkles. And what happens then?
That's sores.
Yeah. Good. Any questions on all of that? Wow, that was a lot of information. Look how far you've come.
It doesn't seem like a lot going over it
Yeah.
now.
Yeah.
So it was kind of easy to learn.
Oh yeah.
Okay. But I want you to think about that. I want you to think about how far you've come in 3 weeks.
Not even
Crazy is only that long. We'll be able to teach us.
Brownie points. I want you to understand when you go to take the test, because right now you're starting to think about the test. It's in your windshield. It's coming up. Some of you have not registered for the test because you got some confidence issues. I know that. I've been teaching for 17 years. I know what's going through your minds. I get it. I don't want you to have confidence in you, but you should after going through that. I want you to have confidence in me. You're ready. We're going to learn the rest of the skills. And the rest of the skills, we're just going to rehash what we've already learned. There's nothing new. We're just going to repurpose all of these steps in other orders on other body parts. So you guys have the knowledge. I want you to register for the test. Don't wait. I can't tell you how many students throughout my time teaching have sat through the class, left, never registered for the test because they never felt like they were ready. And then the longer they get from the class, the more they forget, the more their confidence goes down. And then they come take the class again in 2 years and give me more money. While I love your money, I don't want to see you back. I want you to take the test and go out there and work because those patients need you.
You want to see us back for good reasons.
Absolutely. Absolutely. I want you to come celebrate your successes with me. Okay. Good. Make sense?
I'm gonna come in here with food and be like, Miss Patty, we're having a party.
Awesome. Clearly, I like food. Never turn down a cookie. All right. So everybody good with all of that? Everything that we went over? Good moving forward. Okay. So we're going to now learn a couple of new skills. Now, we still have 2 range of motions that we did not get to earlier in the program. I'm going to pull one of them in today toward the end of today's lessons. And we'll do the last one on Monday. But range of motions are literally 2-minute skills. So it's not going to take me much to teach you. We do. We have Monday and Wednesday. Yep.
But Monday is the last day for the CPR.
Right. So Monday in the afternoon, I'm teaching CPR. So if you need CPR, you don't need it for the class. You don't need it to take the test. You will need it to work. So after you graduate, the cost goes up. While you're in class, so the class that I'm teaching on Monday, you'll pay $45 for your certification. After Wednesday, if you come take my class, it goes up to $55. So save yourself $10 and come to Monday's class if you haven't got your certification.
Do you still have flashcards and like the practice?
I do.
Okay.
So the flashcards and the practice kit are still going to be at that student rate until graduation,
Okay.
through graduation day. Okay. So good. Any questions? All right. Before we get into today's lesson, because I was talking to you about those employers need you, we actually got an email. My phone is somewhere. We actually got an email from Encompass Health, which is on 50. It's the rehab hospital. It used to be Health South, now it's Encompass. They are desperately looking for you. She sent me an email and said, please have your students come and apply. They can hire you before you get certified. You don't need a certification to work there. They'll pay you a little bit more once you get your certification. It's Encompass Health on 50 in Spring Hill. Yep, on 50. Well, their address is technically Brooksville, but everything on 50 is Brooksville. Yeah, Cortez Boulevard.
What position will they hire you for your license?
Nurse tech, or yeah, I think it's nurse tech or rehab tech. I think that's their title.
You know the pay rate?
No. No.
Sorry, I mean that don't matter.
It's rehab tech or rehab nurse.
Yeah, it's something like that. It's not going to be CNA because they can't call you a CNA until you're certified. So it'll be some other tech position. That's like if you go into a hospital's jobs board, you won't see CNA in most times. You'll see patient care tech. That's because you aren't required to be certified to work in the hospital. So they can hire people that are trained. Yeah, and they want you trained for sure.
Yeah, I keep applying and everyone's emailing me back. They're like, "Do you have your certification yet?" I'm like, "No." I'm working on it.
But I will. Yeah.
Yeah,
All right. So Encompass is looking, and there's a million others. We've got all of those. That's my employer corner. Every time an employer contacts me via email or comes in, we have a lot of them that come in because they shop with us. We have a lot of them that come in and say, hey, we're hiring. So I usually just put their information up there.
Can I ask something? Because I was looking the other day online, especially like the hospice section, which I really want, and like it'll say 6 months of experience or like work experience. Do they kind of count if you've already been a caregiver?
Yes. So here's
but not at like I did my mother-in-law, my mom, my husband, like
apply and explain.
Okay.
The reason is, let me explain. And guys, I am so sorry, but I'm going to have to sit down because my knee is killing me today. I don't like to sit down when I'm teaching, but my knee hurts. Okay. So let me explain why, particularly home care positions are going to ask for people with experience. Why? Well, when you're in a facility and you're brand new, you're going to be slow. We know you're going to be slow. You're new. It's the one time in your life you're allowed to be slow and get away with it, right? So, but in a facility, there are other people to help you refine your skills, learn how to modify your time management to speed up, right? To get you up to speed. There's people there. But when you're going to work in home care and hospice, and you have to, especially if you're doing visits, right? If you're slow and you're going to, let's say, Henry's house, and you're supposed to give Henry a shower, change his linens, and make him a sandwich. are all, normal tasks that you would do. If that process takes you 2 hours because you're new and you're slow, all of your patients aren't going to get seen. And these are people that rely on you because you're the only thing that's keeping them from having to go into a facility. So that's why a lot of these positions, particularly ones that aren't inside a facility, are going to be experience required. They need to know that you've had that time to work on your skill level, your
Time
prioritization, your time management, your organization, and you can service the patients adequately within a good time period. So that's why you would see that. Does that make sense? Okay, this is a good time to talk to you guys about my workplace personality quiz, because I heard some of you talking today when I walked in. How many of you guys, and this is funny, but how many of you guys think that you might want to work in a hospital? Yep. Consistent. I'm not saying you can't. Okay? Not saying you can't. But first of all, it's not Grey's Anatomy. Dr. McDreamy is nowhere to be found. Okay? So a lot of us base our idea of working in a workplace based on criteria that doesn't actually exist. So that's the first thing that I would caution you about. But the other thing that I'm going to caution you about, I'm not going to say it's a bad thing to go to work at a hospital. It's not, but hospitals have the sickest people in our community. The sickest. That means they're going to need the most care, right? And there's a whole lot of them. So the hospitals are going to require a certain amount of speed for you to be efficient. Do you think you have that speed at this point? Not yet. So if hospital is your goal and you don't want to go anywhere else to develop that speed, then you probably ought to spend some time in the skills lab honing your skills so that you can speak with confidence in an interview. I may be new, but I'm not slow. And I'm willing to learn. You're going to have to sell yourself because they've taken chances on other brand new CNAs before that have let them down. So you're going to have to really sell it. Does that make sense?
Yes.
Really sell it.
I think a lot of people want to go into the hospital because it's the easiest. Because a lot of people are not just going to stop at CNA; they want to move up. So sometimes when you're in the hospital, it's the easiest way to move up. Because
Right.
You can do the LPN program and then become an RN and all that.
I've actually been reading, someone posted on a group page that I'm on that a lot of the hospitals around here are actually getting rid of their CNAs and like specifically looking for LPNs and higher up. Like a lot of hospitals aren't even looking for CNAs anymore.
Yeah.
That's not in our area.
Not in our, yeah, okay.
Not in our area. No.
Because I think any healthcare is hiring is like really bad. Like
Yeah,
I
everybody's.
see it everywhere around here. I just saw it on
Yeah,
the group pages.
and that you'll see a lot of times there's regional changes that happen in certain
It
regions.
seems like Tampa's what everyone's complaining about. Is
Yeah.
the Tampa area, they're all getting rid of like the lower dogs.
So let's discuss, and we'll get into skills in just a minute. I am going to talk about skills in just a minute, but let's discuss that for a second. Let me go back to where I started with this conversation, though. Okay. The quiz that I created on my website, the workplace personality quiz, it's, I think, 19 questions. It has really not much to do with healthcare. It's all about your personality traits. If you are a person that really likes teams, camaraderie, if you go into a work setting and you make friends with everybody and you organize the potlucks and, all of that, you like being part of a group, home care is not your friend. Right?
Because you're by yourself.
Right, because you're by yourself and you're going to crave that connection that's not going to be there. And that will lead you to be very dissatisfied with your job. Does that make sense? So your personality is going to play a part in you being able to thrive in certain workplaces. You also have to look at what kind of healthcare do you like to perform. Are you the type of person that really likes high energy, complex, lots of tubes and machines and beeping and lots of different types of people working in the environment? Well, in that case, the hospital might be a good place for you because that's where all of that high tech stuff is going to be. But if you're the type of person that panics when you see all of this machines and there's beeping and you don't know what to do and you get paralyzed, well, the hospital may not be your ideal place, right? So you also have to think about what kind of shifts do you want to work? Do you want to work 8-hour shifts or do you want to work 12-hour shifts? Do you need something that's going to be very flexible, like visits in home care or hospice? Or do you not want to travel anywhere and you need a set place to be? Those are going to play into your decision on where the best place to work will be. Do you like working with children? Or do you like working with older people and hearing the stories?
It's
Okay.
always a good show when you hear those stories.
Absolutely.
Sometimes it's sad, but
So we have to start thinking about things beyond, hospital, nursing home, home health, PDA. We have to start looking at the details about what makes that place a place and what makes it different than other places.
So I seen I have a friend in Fort Lauderdale and she's a CNA. She built her own shift. Like she have this app, she go online and she can actually pick up her clients or anything, work a double.
Mm-hmm.
So yeah. So that's a good thing too.
Right. But if you're the type of person that has to work a specific schedule because you've got daycare or you've got transportation issues, that may not work very well for you because the shifts that you need may not ever show up because they get snapped up really quick. So you have to think about your specific needs, and they're going to be different than hers, and they'll be different from yours. And that's what that workplace quiz does. It's free, but I would suggest that all of you take it to help narrow down and to help you see some of the considerations that you need to think about when you're deciding where to apply. You're going to be in demand. Guys, everybody out there is hiring. It's not that you're going to be begging for a job and taking the first thing that you come across. You're going to be in demand, which means that you've got to make the best decision for you so that you can get into a place where you're going to thrive. Okay? Now, let me explain to you why that's so important and why I'm adamant about this and why I spent that quiz took me a year to develop. There was an incredible amount of psychology that went into that quiz. And then I field tested it on about roughly 500 currently working individuals to make sure it was accurate. It works. But let me explain to you why I'm so adamant about this. Let's say, and I'll pick on you, Chelsea. Let's say that Chelsea has it in her head that she wants to work at a hospital. That's the only place that she's willing to go. And she goes to the hospital, she gets hired, she starts working. And it completely overwhelms her because there's way too many patients, there's way too many things to do with those patients. She can't ever find the nurses to report stuff, her observations to. The computerized documentation program, the electronic health record is very complex and she doesn't know what to do with it. And she is out of her league and over her head, and she quits. Now, chances are, on top of that, she probably had some coworkers that were less than nice, because that's unfortunately reality. Okay. So chances are when she quits that hospital, she's not going to just quit the hospital. She's going to quit healthcare. It's going to leave such a bad taste in her mouth that she's not willing to try somewhere else. So that means that she just wasted all the money for taking the class. She wasted all of that time preparing for a career that is no longer an option for her. And we now have a position open that is not being filled. And that's going to ultimately affect those patients. So it is imperative that you understand the setting that you're most likely to succeed in right out of the gate so that you aren't likely to leave healthcare. We need you. Okay. It's easier to deal with uncomfortable people when you're secure in your position. But if you're not secure in your position and you have to deal with personality conflicts, it becomes really overwhelming. Does that make sense? So take the quiz. It'll help you. All right. And it may even help you understand a little bit about yourself that you didn't think about. All right. Esme says, hi, Miss P. My name is Esme and I'm watching from South Africa. Wow. I'm really interested in becoming a CNA when I move to the USA. What are the requirements if you want to study CNA? Thank you. Thank you, Caitlin. Oh. It depends on what state you go to. The United States is a very, very, very large country. It has a lot of different states, and every state has a different set of requirements. So you'd want to look into the requirements in the state that you're looking to move to. If you come to Florida, you can challenge the CNA exam. Just watch my live streams. It'll get you everything that you need. Order the book, this book, so you can keep up. And you can prepare to challenge the exam that way. Other states are going to require that you take a classroom program to be eligible to test. All right, so let's. Oh, thank you. Thank you, Raz. Oh, win-win. Thank you. You guys are awesome.
What did you say? That the Encompass Health place?
Encompass is on 50 on Cortez Boulevard in Spring Hill, and they are currently hiring
For what?
for techs.
Like Matex or like
No, it's just nurse tech or rehab tech. Just let them know that the education coordinator reached out to me. Just let them know that your instructor told you that their education coordinator was looking for applicants. You're there to apply. Not CNA certified yet, but you will be shortly.
Yes, we will be.
And remember, you don't have to be to work there. They just want you trained. All right. So any questions on any of that? Trying to figure out where you want to work? Let's get into the new skill we're going to learn today. Okay. Let's go to transfer from bed to wheelchairs. It's on page 72 of your skills book. And if you look at this page, you'll notice we already know all of the principles involved. We know how to follow the care plan. We know how to do the opening. We know to evaluate whether we need gloves. We know shoe rules, and we know the closing. So what we need to learn here are skill-specific steps, things that are specific to this skill. So let's jump into that. And there's a lot to learn here, guys, as far as skill-specific. None of it is hard. None of it's hard, but there's a few things we have to go over. So if you look on page 73 at the top of the screen, you'll see your care plan. What do we do with care plan? Yeah, we read it and follow it. So this care plan tells us to transfer the resident. Oh, let me just read it out of here. I can't turn that way. All right, transfer the resident from bed into a wheelchair. The resident is unable to walk or take steps. Stop there for a second. I want you to underline that or highlight it or do something with it. Unable to walk or take steps. That is the important part of this care plan. Unable to walk or take steps. A gate belt or transfer belt is required to transfer the resident, and the resident will stay in the room. If you were going to stay in the room, would you want to be facing a wall? So at the end of the skill, if the resident's staying in the room, where should we be positioning them? Window, TV, door, something.
Wherever they prefer.
Yeah, something. Yeah, just don't leave them facing a wall and think your skill is done. All right. So what do we need to know about this skill? Well, this is going to involve shoe rules. That means if the patient's feet hit the floor, we got to talk about their shoes. This patient is starting out in bed. They're not going to have shoes on. Remember, ambulate with gait belt, they did. We didn't have to put shoes on. They already had them. But this guy's in bed. They don't have shoes on. So we're going to need to put shoes on them. So how many of you guys wear shoes? Okay, do you put your shoes on before you get out of bed in the morning? No, nobody does that, right? So don't put your patient's shoes on while they're in bed. We got to get them sitting on the side of the bed first, and then we'll put the shoes on. Let their feet dangle. That's right. Does that make sense? Yeah, don't put shoes in the bed, guys. That just makes your sheets all icky. Don't do that. Yeah, let's get them sitting on the side of the bed first, then we'll put those shoes on. Remember that slipper socks are never enough. We want to make sure those shoes are on before we transfer them. That's important. All right, so gait belt's going to go on. How do we know if it's snug enough?
4 fingers.
4 fingers, okay. We want to verbally acknowledge that those feet are flat
On the floor.
before we lift the patient. Why is that important?
The way they don't help towards you.
Okay, so far this sounds a whole lot like ambulate with gait belt, doesn't it? Okay, so this skill is like ambulate with gait belt with a few extra steps. Before we move a patient, we're always going to make them a partner. So how do we do that? Count to 3 before we lift them. We're going to use that same oblique angle. So far again, sounds a whole lot like ambulate with a gait belt. So this is where it starts to change, okay? When we're transferring somebody from bed to wheelchair, we're not walking them. And in fact, I had you underline in your book that it specifically says that they cannot walk or take steps. So that's going to be very important. We've got to make sure that that wheelchair is close enough that the patient does not have to take a step, because our care plan says that they can't. Okay. So
probably like what's it called? They have no feeling in their legs. That's most
could be a million different reasons. It could be that they just had a hip replacement and those muscles haven't healed enough to move that leg. It could be that they're paralyzed. It could be that they've had a stroke. It could be that they have a progressive neuromuscular condition.
So say they're just too weak.
It could be that they're very weak. There could be a million reasons. It's just important for us to know that they can't take steps.
Would a pivot be considered a step? Like if
Actually, no, because with a pivot, we're doing the work. Step requires the patient to physically move their foot on their own. So a pivot, we're doing the work. Step, they're doing the work. And our care plan says that they can't. Okay. Ideally, you're going to be transferring to all kinds of patients. Ideally, they'll be able to take steps. This one can't. All right. So now, we just talked about that. Now let's talk about the steps involved. So our patient starts out laying in bed. I've got to get them sitting on the side of the bed before I put the gait belt on and the shoes on and all of that. I'm going to show you how to do that and make it easy. A lot of you guys think there's no way I can do that. I don't have the upper body strength. You actually do. It's just like turning a patient. Remember I said if we set it up right, it becomes very easy. We're going to do the same thing with this. If we set it up right, pivoting somebody so they're sitting on the edge of the bed actually becomes pretty easy. Okay, I'll show you how to do that. But we don't want that wheelchair super close to the bed because I'm going to be swinging those legs off the bed. And if the wheelchair is right there, that means the legs are going to get all tangled up in the wheelchair and somebody's going to get hurt. Could be me. So we want that wheelchair within reach, but not super close to the bed yet. We're going to get our patient pivoted and sitting, get their shoes on, get our gait belt on, and then we'll bring that wheelchair close, super close, so they don't have to take steps. Okay, good? You guys understand why? Let's talk about brakes. Wheelchair safety is all about brakes. Brakes, brakes, and more brakes. If the wheelchair is not in motion, the brakes should be on. Brakes are not considered a restraint. They're right there in the open. Anybody that has the ability can reach over, unlock the wheelchair, and go anywhere they please. Brakes are not a restraint. They are a safety measure. And that's because floors in most clinical settings are not level. In Florida, most of our floors are concrete. Concrete tends to settle, and you end up with very minor waves that it's not completely level. Some places the floor will be wood, and wood tends to warp. So those floors will not be completely level. You guys see that? If we have a wheelchair with a body in it, let's just say the body is 150 pounds in the wheelchair, and it's unlocked on an unlevel floor, what's going to happen? It's going to roll. And as it rolls, it will pick up momentum because there's weight to it. So the only thing that's going to stop that wheelchair is whatever it runs into. There's a body in that wheelchair. Brakes are safety. This is tragic. This is horrible. This is unforgivable. And it was the largest negligence verdict in Florida. Unlocked wheelchair, patient unable to move, immobile. That patient saw that stairway come closer and closer and closer and was powerless to stop it and ultimately died.
That person went to jail, correct?
I don't know what the legal ramifications were. I don't know.
Not accessible. Doesn't matter.
I'm using this as a learning opportunity for us.
Yeah.
So that we understand that there are serious patient consequences to violating this rule. So this was what they had in mind when they wrote these standards. If you leave this wheelchair unlocked, you will fail. Why? Because your patient could die. That's right. That is right. And a lot of CNA testers, people that are testing, they will come back and they will say something like, I don't understand why they failed me. I just missed one little step. So is the test about you and you missing one little step? Who's the test about? Patient. So if we think about these steps in relationship to what effect they have on the patient, they no longer look little, do they? That's what I want you to remember when you go into the test. Okay. All right, so wheelchair brakes are not a restraint. They're a safety measure. Anybody that can unlock a wheelchair is free to roam. No problem. If you have somebody in a wheelchair, don't restrain them to keep them from wandering. That is false imprisonment. I have seen CNAs use gait belts to tie patients to a wheelchair. I have seen CNAs take a mop handle and put it in the spokes of the wheelchair to keep them from rolling. I have seen CNAs tie a wheelchair to the safety railing in a hallway.
I know they could really figure out a way to fall out the wheelchair.
Absolutely. Now, all of those measures, were there any of them to help the patient?
No.
What were they all about?
CNAs.
That's just common sense right there. I'm sorry, but
Yeah.
Why would there be a seatbelt? Because it said in the
Yeah, they did not want the patient to get up out of the wheelchair.
I guess the care plan would tell us if we would use a seatbelt.
A seatbelt is a restraint. Who has to order that?
Doctor.
Doctor, that's right. That's right. Can CNAs ever implement that on their own? That's where the problem is.
so the care plan's gonna say they need a belt because that means they're gonna get up and we're gonna help them.
Right. If the patient is unaware, we don't use seat belts because the patient can actually slide out of that wheelchair. And where would the seat belt end up? Yeah. We generally don't use seat belts. We have something called a lap buddy, which is a really soft foam pad that fits like a tray on top and keeps the patient from being injured. So that would be in the care plan. But that's not really what I want to focus on with this. So remember that anything that restricts a patient's motion, freedom of movement, is considered and requires a doctor's order. Good. We can't make those decisions ourselves. And this is vitally important with wheelchairs. I don't know why, but CNAs, for some reason, get this all mixed up. And they think if a patient is in a wheelchair, they can take whatever measures necessary to keep that patient from standing up on their own. You're not allowed to do that on your own. If your patient is in a wheelchair and in danger of standing up without taking the appropriate safety steps, who would you notify? That is not a problem for you to solve on your own. Does that make sense? Okay. Be careful with that. So let's talk about wheelchairs. If your patient can't engage or disengage the brakes, they definitely need to be on because they have no way of stopping that wheelchair if it starts to roll. Okay, those brakes definitely need to be on. So brakes are always safety, always safety. Wheelchairs should be locked when not actively in use. Now, wheelchairs are usually higher than regular chairs. You can see that here. I actually used one of those chairs. So this wheelchair, if you look at the seat height, is different. That's because chairs, these guys, we want your feet flat on the floor for most of you. Not me, but most of you. Okay. Wheelchairs, the whole purpose of a wheelchair is to make the patient mobile. We don't want their feet flat on the floor because then the feet will drag and they could get injured. So we don't want the feet flat on the floor. Got it? So wheelchairs are going to be higher. Well, that creates a problem, and it's a problem we need to be aware of. When we have a higher seat, that means the legs are going to dangle. And dangling legs have a serious issue. So if you look here, this is the backside of a body. We have veins in blue and arteries in red. Arteries take blood to the feet. Veins bring blood back to the heart from the feet. Good? Okay. Do you see where those veins and arteries run? Okay. When we sit in a wheelchair, that seat presses up into the backs of the knees. And if the feet are just dangling, that means all the patient's leg weight is pressing down on those veins. So the blood, remember, veins bring blood back from the feet to the heart. So if we crimp off those veins, is the blood going to be able to circulate? No, so we end up with swelling. Now, anytime blood slows down or stops, it clots. So what is this patient at risk of? Blood clots. So swelling will happen. Blood clots could happen. Are we doing our patient any favors here? No. So anytime we have a patient in a wheelchair and their legs are dangling, we have to support them with the foot pedals. This is what happens on the inside of those veins. Inside the veins are little valves. As the heart beats, it pushes the blood up through the valves close, and it creates like a ladder for the blood to climb up. So we have a vein. The blood is going to advance through each of these little chambers. If we crimp them, it closes off that valve. Nothing can move up. That means all of these cells are going to clump together and clot. That's how blood clots form. And we can relieve that simply by supporting those feet on the foot pedals. So are foot pedals important?
Yes.
All right. So there's something different between foot pedals and leg rests. So let me show you the difference here. I'm going to have to stand to teach now. Let me get a wheelchair.
Yeah, I was like,
Okay. Oh, wheelchair 101. Okay, so this is a wheelchair. Wheelchairs are usually kept in the folded position for storage, like this. To open a wheelchair to use for a patient, we use these handles, lift up on the handles so that the wheels themselves are up off the floor, like this, just a little bit. And then we're going to open the wheelchair. There's no buttons to push, levers to pull. It's just open. If you don't lift up, though, those wheels are friction and it kind of makes it harder. You have to use more force. But if you notice, it didn't open all the way. So in order to finish opening this wheelchair, I'm going to press down on these bars, and that's going to open the rest of the wheelchair. But I don't want my fingers down here, because as this seat opens, it's going to trap my fingers there and pinch them. So I always keep my fingers up when I press that down. Okay. That one over there opens a whole lot easier. You pull it open, it opens all the way. Every wheelchair is a little bit different. They all have their own personalities. Okay. So we have a wheelchair. This wheelchair has brakes in front of the wheels. This one works a little different than that one. I've got two wheelchairs. They both work a little bit differently. You want to familiarize yourself with both. This wheelchair, you have to press forward on the lever to engage the brake. That one, you pull back on the lever to engage the brake. How that works, we'll get to brakes in a minute. I got ahead of myself, sorry. Leg rests. So these are the foot pedals here. They just fold down to support the feet. And the foot pedals are held in place by leg rests. So if we pull the leg rests or the foot pedals up, these leg rests are like locked in place. So in order to move these out of the way, I can't put a patient into the wheelchair with them like this. The patient could trip. So there's a little catch on the back. If you release the catch, they simply swing out. This is the position we need the leg rests and the foot pedals in before we transfer a patient in or out. Okay? Oops. So if we have a patient in a wheelchair, the foot pedals are down, the leg rests are forward. If we are going to store the wheelchair, the leg rests are forward and foot pedals are up, and we collapse the wheelchair. I'll show you how to do that. And then when we're transferring, everything is out of the way. So this right here is a transfer position. Okay, leg rests, foot pedals out of the way. Of course, it would be locked. This is for storage. Okay, storage. You want those leg rests locked in place for storage because you're going to move this somewhere. If those leg rests are not locked in place, they flap all over and they can hurt somebody. Good? Good. And then when in use, when we have a patient in, we get the patient in the wheelchair, leg rests forward, foot pedals down to support those feet. All right. This is horrible. So this happened in Georgia not too long ago. This was a unit secretary. She was non-medical. She was a unit secretary. This happened in radiology. Patient was there to have an x-ray, I think, or a CT or something. Patient's daughter comes up in the car. Patient is in a wheelchair. The non-medical person was trying to do a good thing and help the patient outside and into the car. Sounds, I mean, they were doing a good thing, but she did not know that these foot pedals and leg rests had to be moved. So when she transferred the patient out, the patient tripped outside over the foot pedals onto the curb. Her foot got trapped and she broke her leg. So we got to know how to use these right. Okay. All of these legal issues are what form the basis of your test. That's why these steps are graded so harshly.
Is that why things change too? Because when stuff occurs, like issues, then they have to address it.
Sure, because we don't always know, right? We don't have a crystal ball. We can't see all problems before they occur. We can guess at what some problems might be. We can prepare for some, but we'll never prepare for all. You know, fluke things happen. Well, every time something happens, there's a team of people that look at that something, whatever happened, and they try to dissect, why did it happen? Where was the point of failure? What can we do to prevent this from ever happening again? And that's how new policies are made. Okay. That's actually, there's a whole part of medicine devoted to that. It's called continuous quality improvement. And it's a really fascinating part of medicine because it's not about blame. It's about how can we improve. Okay. That AC is having issues. All right, so before we put a patient into the wheelchair, we're going to fold the foot pedals up, move the leg rests out of the way, lock it. That's our position for transfers. Once we get the foot pedals up, leg rests out, we're ready. We got to get the patient sitting on the bed. We don't want the wheelchair super close yet. We're going to pivot that patient so they're sitting on the side of the bed. I'll show you how to do that. And then we'll put the patient's shoes on, make sure their feet are flat on the floor, put the gait belt on, and we're going to get this wheelchair close. Remember, our care plan says they cannot take steps. So if you look at this, I'm going to need this today too. If you look at this, do you see how close that wheelchair is to the patient? Maybe an inch. That's what we're looking for. Because if I pick this patient up and just spin them, their feet don't have to take steps. I can set them right down in the wheelchair. But if I've got the wheelchair way out here, they're unconsciously going to take a step during the test. This is probably the most important thing I need you to understand. That wheelchair has to be close. If you think it's close enough, it's probably not. It's got to be less than an inch from the patient. Okay. We also want to make sure the wheelchair is locked. Anytime we put somebody in, take somebody out, that wheelchair needs to be locked. We'll check the gait belt with 4 fingers. And we'll brace the patient's feet with our foot before we lift them, just like we did with Ambulate with a gait belt. Want to use that oblique method, standing at the corner. We're going to pick the patient up and pivot them. But just like with Ambulate, they need to know that chair is behind them. So I'm going to ask them, can you feel the seat behind you? But remember, I'm holding their weight. That's a long time to hold their weight. Pick them up, Swing around. Can you feel the wheelchair behind you? They've got to think about it. Do they feel it? They got to tell me yes, and I got to sit them down. It's a long time. I don't want to be holding anybody that long. So this is what I do. Before I pick the patient up, I tell them, I'm going to pick you up and swing you around. When you feel that seat behind you, I want you to say sit. Okay? So I'm going to pick you up, swing you around. When you feel the seat, you're going to say sit. Ready? Here we go. Remember to say sit when you feel the seat. Put your hands up here. Hold. 1, 2, 3. Sit. There we go. Okay. Good. Make sense? Okay. We want to pivot them smoothly without them having to take a step. Make sure they feel that seat behind them. And then we'll position the feet on the foot pedals. We are going to spin the wheelchair so that they're not facing the wall. We'll take that gate belt off. We're going to leave them in a locked wheelchair and ensure that they're sitting properly. So good? Then we'll do the closing. All right. So hopefully my leg will let me do this. All right. I'm going to need, hold on. Nope. Hold on. I'm going to move her. I want you to come lay down in the bed. Just take your shoes off and put them beside the bed.
Okay.
So for the test, for this skill, they are going to pair you with somebody your body size or smaller. And they're actually going to look around for somebody who has slip-on shoes to make this a little bit easier for you during the test, a little quicker. Where do those evaluators want to be? Yeah, they don't want to watch you put shoes on somebody and tie them and all of that. So they'll look for somebody with slip-on shoes. I got her.
Whoa. Oh my gosh, her ankle.
I'm glad that's not on video. Okay, go ahead and lay down. Oh, yeah. Don't look at her. Okay. All right, I'm going to turn this camera. No, it's not working today. All right. So I've got a wheelchair. It's in the room at the beginning of the skill. Okay, in the room. Not close to the patient, it's just in the room. And it'll probably be like this. Unlocked, foot pedals down, leg rest forward. Is this the right position?
No.
I'm going to have to address that. Keep that in mind. But every skill starts with the, so I've got to start there. Here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to get you out of bed and into a wheelchair. Does that sound okay? All right. I'm going to close your curtain for privacy. Let me go wash my hands, get my supplies. I'll be right back. I have clean hands. So I'm going to get my gate belt. Wow, I don't know why my knee hurts. All right. And I'm going to prepare my wheelchair by folding up the foot pedals and swinging the leg rest out of the way. I want it within reach at a slight angle. So I'm just going to kind of leave it here. That way I can grab it. Yeah, see, it rolls. That way I can grab it, but it's not in my way to pivot her. Okay. All right, Miss Jones, I'm going to take that sheet off. Is that okay? You're fully clothed? Yay. Okay. All right, can you scoot your whole body toward me? And I'm going to swing you around so you're sitting on the side of the bed, okay? What I need you to do is cross your arms over your chest and relax. This arm is going to go all the way under her shoulders. Her furthest shoulder should be in my palm, not just a little bit. This is what most people do, just a little bit. That doesn't work. I got to go all the way under. This arm is the one everybody gets wrong. It doesn't go under the knees. I'm not going to carry her somewhere. It goes over the knees. So when I do this, it's just a pivot. Okay. All right. So I'm going to put my hand under your shoulders and over your knees. And on the count of 3, we're going to pivot to the side of the bed. But I need you to relax. Okay. So this goes all the way under. Okay. Ready? 1, 2, 3. Okay, good. Are you dizzy? You can relax. Okay. So we put your shoes on. Okay. And can you scoot forward so your feet are flat on the floor? And I'm going to put this gait belt around your waist, okay? We'll put it through the first guard by the alligator teeth. Pull it so it's snug. I'm going to check it with.
4 fingers.
We'll lock it in place. I'm going to bring this super close. Close enough? Nope. Close enough? Nope. Yup. Okay, so we'll lock that in place. It's locked. Everybody ready? Okay, so bring your feet together.
Can I stand up?
Yes. Oh, yeah, absolutely. You're going to put your hands on my shoulders. I'm going to reach around to the back of the gait belt. I'm going to stand you up and spin you. On the count of 3, we're going to do that. After I spin you, when you feel this behind your knees, I want you to say sit. Okay? So I'm going to put my foot here. You're going to put your hands here. And remember, I'm going to lift you up. When you feel that chair, you're going to say sit. Ready? 1, 2, 3. Sit. Okay. I'm going to take this off. Should I pull it?
No.
Okay, lift your arm. Thank you. Okay, I'm going to unlock the wheelchair and we're going to spin around. Lift your feet. Whee.
I do that in the hospitals too when they're transferring me.
Yep. Okay, and I'm going to lock that. I like to have fun too. And I'm going to lock this side. And she's not facing the wall. She's facing you guys. Entertainment. I'm going to lift her leg from below and place her foot on the foot pedal. We're going to do the same thing on this side. I'm going to lift from below. Fold that down. There you go. It's locked. Let's see if I can get that call light. All right, here's your call light. Can you reach that?
Yes, I can.
Is there anything else I can get for you while I'm here?
No, I'm okay.
Are you comfortable?
Yes, I am.
Okay. She's safe. Environment is clean. I personally would probably pull that sheet up and just make it a little bit neater because that's me, but it's not required. All right. If you need anything, please use the call light. Just hit the red button and I'll come back in. I'm going to open the curtain, put my gait belt away, wash my hands, think about the steps of my skill, make any corrections, and tell the evaluator my skill is done. Okay. All right. So don't get up yet. Don't get up yet. Let me go ahead and lift your foot. Let me take this. There you go. You are free to roam.
Now, I do have a quick question.
Yes.
You said earlier that like the breaks aren't restraints; they can go willing or wherever they want. Now, with the case, like with the dementia case and everything, you don't leave them alone in a wheelchair, do you?
Care plan. Care plan, care plan, care plan. I can't give you one answer that's going to cover every situation you might come across. Some patients with dementia, absolutely, because they have no idea how to use the brakes. Other patients with dementia, the wheelchair may not be appropriate. We may want to use what we call a Jerry chair, which is like a recliner.
Okay.
Or we may want a adult walker, which is a big PVC walker with a seat, and they can just walk around.
Okay.
But it keeps them from going out of the doors because it's too big.
Yeah.
So every situation is going to be a little bit different.
Gotcha. Okay.
And unfortunately, I can't give you that one answer. Yeah, just follow the care plan. All right. So any questions on that? Any questions on that? Okay, let's go ahead and take our break. Come back at 10 after, and we're going to get into feeding.
Here, I need it.
Oh my goodness gracious. That's my show, Mr. Yeah, bro. Yeah.
Keep that camera off of me.
Go in the bathroom.
The wheelchair and the gestures, I think those are the two that I'm gonna bring it up. Is it? It depends what the assignment. Yeah. They're gonna send you like the computer kind of picture of the schedule. This will be gesture, the wheelchair, it could be everything. You can't, why can't we just pick whatever we want? I don't know. I just feel like because then we know what the person on it and we can read that. So I just feel like they just know. Whatever. Are you gonna be taking a CPR class next week? No, because when I go, maybe in February, because my program's actually not a good time to pay for it. Gotcha.
So you applied for your exam already?
Who, me?
Oh no.
I just feel like I'm not ready. I don't know. I just feel like I'm just not ready for the exam.
Right, I feel you. I'm nervous, but I'm gonna apply for the exam 31st. I mean, if I fail one, I can just retake the one I failed.
Yeah.
So I'm aiming to at least pass one of them. But if I do end up passing both, that's great, you know?
Like for me, I feel like the two that I'm really gonna get confused on, if I get them, is gonna be the dentures and the wheelchair. I'm just not
So you
sure.
think you got Perineal Care already?
Yeah, I feel like most of them I'm pretty good at. I know I can do it, but I feel like these two, I know I'm gonna skip something.
Right, I feel you. But if you got everything else, you can do dentures and wheelchair. I mean, wheelchair is kind of like gait belt,
Yeah.
but like you're not walking, you just put them in a wheelchair.
Yeah.
So I think you got it.
Hopefully.
Just study. You got to study.
Oh yeah, I'm
Yeah,
trying
I
every
at all
day.
them videos, not just the end, like the 11
I'm
hours,
doing
but
everything that I can just to
Looking at
study,
all
get
the videos.
myself ready for the state exam.
Mm-hmm.
Just do everything I can. Hopefully, let's see.
Yeah, we got this. We got this, y'all.
Me, I'm taking extra time on the exam, so I'm like being extra cautious about it.
Right, I think you can get it read to you too. The writing part. So I'm probably gonna do that one. You know, just y'all read it to me.
Yeah.
Save my
I know,
eyes and brain for the
I know she said
skills.
it's easy, but I'm like, I'm just being extra cautious.
I know exactly. I know she's saying like it's gonna be easy, maybe, but for us, like until that day, we're just going to be confused. You know, once you walk in, you're gonna be
It's
like, oh my
I
god,
forgot it.
I forgot it.
Let me just go.
And plus, you're
Be
only
scheduled.
learning a month of school. You're only learning just a month and 2 days.
Yeah, it's just like 1 month where you're covering like everything. So I just feel like I'm gonna need just a little bit more time just to cover everything else. Once I get comfortable, I'm just gonna register for the exam. Yeah, right now I'm like, I'm not that comfortable right now.
Well, you just go with your gut, damn it. If you want to wait, wait.
Yeah. So for the CPR next Monday, what time did she say it's going to be?
I don't know.
At 2 p.m.
2 p.m. So 2 p.m.
Yeah, because I gotta come that one too.
No, I want to do that. I definitely want to come in Monday and get that done.
Mm-hmm.
I just feel like it's good to have.
Yeah, and wherever you go, wherever you work at, they're gonna want you to have CPR.
Exactly. So it's good to have the certification.
And I feel like every class I did CPR, they never really taught me the right way. But I feel like it's that. How do you work that?
Yeah, there's like some parts where I'm super comfortable, you know, the way she's teaching, I just get it. But you know, when you have a lot of steps, it's unskilled. It just goes through your mind. You don't know how to do it. So those are the only. Huh?
I feel like this one.
I'm pretty good at that.
At what?
Yeah, the test homework, I feel like I'm pretty comfortable, you know.
Yeah.
Because you have everything in front of you.
Yeah, and you
can, you know, get those answers right off. So I think I'm pretty good with that. The test, the state exam.
Yeah, we can't use no book. You gotta remember.
I just feel like I'm gonna make flashcards, and while I'm going to temp, I'm gonna look through.
Right.
I'm just gonna look.
Girl, use your hands right now. Some like little side.
They're gonna kick us out.
Oh yeah, they're for sure.
You're cheating. You're not.
They're gonna be like, you can go, Belle. No, no cheating here. Oh yeah, let's see. Right now, it's so I feel like I'm gonna, once I get into these classes, that's really when I'm gonna go through my books and taking all the notes, just memorize it every day. So I don't forget it.
Yeah, I'm just hoping that my freaking program is for you time for real.
You know, I don't want to forget anything, and it's like, you know, it's going to waste. Like, what is it? Let's see. Hopefully. Like, the state exam is not cute. That scares me. I get nervous. For these exams, I get nervous.
I think that's sufficient reading. Take it as
Really? My sister, she's a cosmetologist. So, and you know, she had to take a state exam back in Connecticut. She had to. It was a must. So when she was like reading these big books, and she was going through everything, and she's like, once I entered, There was written exam. I just went through it and I knew every answer she passed with that 80 seconds. And I'm like, for me, it's like, it's not just the written that we're getting graded, it's the practicals that we're doing, the skills that we're performing on someone that completely don't know. It's random on top of it. That's like, big. I don't know.
Can't believe we had one more before.
Oh yeah.
That you started.
That way we never see each other. We see y'all ever again.
Yeah.
Last time, last week.
I just feel
hope
like
you guys
once we
get
start
started.
knowing each other, like we're just starting to know each other, and the
Right.
class is already ending, and we're like, oh great.
Right.
I feel like Wednesday's gonna be good. Like they're gonna just pass out the photos, like the certification, like diploma, and that's it, right? I think we're gonna do anything on Wednesday, are we?
I might end this short on Wednesday.
I think she's gonna end the show on Wednesday because we have absolutely nothing to do. But let's see.
Looks like they have to have a money for both. Right, because it's boom, boom, boom. Yeah. Oh, it's cold in here. It is worse. But I'll come in now.
Oh yeah, that's how warm it was. Yeah, my phone, my phone.
Oh, yeah.
That's like the time when we do it, so I just enjoy myself.
I was doing it now. I started outside today. But like when it was cold, you can see me in here.
When it's cold, I'm in my bed.
Has anybody been to the Thai restaurant that is on 19 in like the rural King Plaza?
No.
I'm very scared to try places in
What is it called?
plazas.
I don't know what the name of it. I know it's a Thai restaurant. It's like near Harbor Freight. It's in that plaza, like Harbor Freight, Big Lots.
Well, if you go, let me know how it is.
I know. I saw it the other day, and my girlfriend's like, "Oh, we should go there," and I'm like,
Yeah, I like trying new places. I thought it was a Greek place.
In
down
this
the road,
book,
too.
that test at the end, is that very similar to?
We're gonna, yeah, we'll go over that. I'm gonna talk about that at the end of class today.
Okay.
I've never really ate Thai food though.
no, I like. There's a Thai place on 50 near Hobby Lobby. That place is really good, Thai spice. But I didn't know about this one.
food.
It's definitely cool to have.
Yes.
I'm very. I like Chinese food, but I like it from back home. I can't
beat it.
I can't find
Same with
it.
some people with pizza in New York, and
Yeah.
they can't beat New York pizza. And I'm
I
like,
can't
I've never
find
been,
it.
so pizza here is great. I love food. I love trying new food, but once I don't like something, I don't like it. You can't keep
I
me
like
around.
food. I like it.
Yeah, I've never been to New York either.
That Polish restaurant.
I don't know. People talk about it. I don't know if I want to go. I don't think I would last. I don't think I would last because here is pretty bad here. Some places, but up there, I heard.
What do you mean, weather-wise? Or like,
No, people.
oh,
Weather, I don't think I would last. Either. I'm too comfortable there. What?
What's that?
Yeah.
be around with.
It's very
I don't want to say
expensive.
something and get like beat up.
Just surroundings.
I've been in Florida my
I
whole life.
move around too much. So
I was
like,
born
don't
here.
get
I've lived here my whole
but I'm
life.
just very aware.
I would like to try somewhere else. I just don't know where. Yeah, I just don't know where. Personally, I'd rather be on a beach in a tiki hut somewhere, but you know, that's not going to happen. So, yeah.
Every weekend.
Depends on the like certain places.
Yeah. Times Square is where all the film goes. So like,
She's like, when I go down that way,
you been?
she lives
Well,
in
I've been there, but I just don't like
and
it.
we meet up
I'm
in
trying to
that
see on
vicinity.
TikTok, yeah.
And we're always like, where do you want to go? I'm like, I don't know where you want to go.
Manhattan's beautiful.
I gotta go. I wanted to Christmas in there. See snow. I never see snow.
Really?
I've never seen snow either.
24.
I hate the snow. And that's
It's nothing really that special.
Oh well, let me just experience.
they're so good.
I'm upset.
It's
I
good
always
to
will
travel,
try
but to
anything.
live there,
Yeah.
No, to drive there too, it sucks.
I mean, I do know
It's like 15 hours.
From here to New York,
quite a bit of stuff.
Yeah, about 22.
Oh, Baker.
No, it's
And
far.
I, like the other day,
No,
I was craving
It's
bread,
not
so I
so.
had to look it took a week.
All right, let's go ahead and get started on feeding while we're waiting for everybody else to come. This is going to be on page 108 of our skills book. And as you can see, there's really nothing much to learn other than skill specific. We know skill rules, we know the opening, we know glove rules, barrier, linen rules, and the closing. So not a whole lot of principles to learn. We're going to use all those principles while we do this skill. So if you look on page 109 at the top, we're going to look at the care plan together. This care plan tells us to feed the resident a snack who is unable to feed him or herself. The resident is sitting in a chair in an inappropriate position for eating. You might want to underline that, inappropriate. If our care plan is telling us that this patient is in an inappropriate position, what do you think the test is going to require that we do? Yeah, make sure they're sitting up. Absolutely. And we can actually do this verbally. We can just ask them, can you please sit up straight? We don't have to physically move them. But if your care plan is pointing out to you that it's inappropriate, it doesn't matter what your eyes are telling you. And that's because if you look at the bottom of page 108, you'll see that this is actually done on a live testing student. That means that you guys might be a patient for feeding. Somebody might feed you. Actual food during the test. So for the test, you would be feeding somebody a small snack size, the single serving of applesauce or pudding. They don't give you choices, guys. It's not a restaurant. You don't get to order from the menu. But it would just be a small single serve. Now, if you're allergic to milk, you need to let them know that. Because if they're going to feed you pudding and you're allergic to milk, that's going to be a problem. Okay, if you're allergic to apples, they need to know that. If it's a preference issue, try to choke it down. Don't be difficult for the test. If it's a texture issue and you will throw up, please let them know that. They don't want you throwing up during the test. Okay. For the exam, when you're the patient for this, you're going to be told to sit in a chair at an overbed table like this, and you're going to be told to slump or slouch. So your idea of slumping and slouching might be a little different. Some of you, it's going to be this. Now, if you look at me, every 12-year-old on the planet has eaten dinner in this position. We may not consider this inappropriate. Remember, don't believe your eyes, believe the care plan. Make sense? Okay. So some people get really into that role and they do stuff like this. Just remember our care plan says inappropriate. So we're going to ask them to please sit up straight. Good. All right. I teach this skill toward the end because it's the one skill that doesn't follow most of our rules. Feeding is the rule breaker. And the reason is we don't close the privacy curtain. We close privacy curtain for every other skill we do, but not this one. And that's because eating is a social event. People gather in groups to eat. Think of all your major milestones in life: birthday parties, baby showers, birthdays, graduations, weddings, funerals, all have food. Backyard barbecues on a Saturday night still revolve around food. So eating tends to be social. But even beyond that, regular day-to-day food is also social. Let's say that you guys all go over to Cody's for lunch after class because it's buy one, get one fajita day. And it is, by the way.
Oh, why?
Yeah. Buy one, get one fajitas on Wednesday. So you all walk in there. And there's about 60 people in the restaurant. And you walk in and it's dead quiet. How awkward would that feel?
I feel like
Very
there's something.
awkward.
My stomach would be like queasy.
Very awkward.
I wouldn't want to eat there.
Okay, so we expect a certain amount of conversation when we go into restaurants, don't we? And that's because eating is social. You tend to have conversations while you eat. No, you're not talking with your mouth full, but somebody else is talking while you're chewing, and then they take a bite while you talk. That's how conversations work when you're eating, but conversation is a definite part of eating. Make sense? So, what do you think a part of this skill is going to require? That's right. You are required to have a conversation. Doesn't have to be a real one. You can make something up. They're showing a movie on the big screen in the activity room later. They're playing bingo later. Did you see the little kids come in for Halloween? I don't care what you talk about. Just talk. Okay. This is not a long skill. This should be done within 9 minutes or less, and only a certain small part of that is going to require conversation. But you do have to have a conversation. But part of socialization is not closing the privacy curtain. When you close a curtain, it isolates the patient, blocks them off from others, and that's going to reduce their socialization. Make sense? Okay, so for this skill, we don't close privacy curtain. We also don't use a barrier on the table because our food tray is our barrier. So we don't need one. Okay. It's also the only skill that requires that you sit. You're not required to sit for any other skill. In fact, most skills, it's easier if you stand. This skill, you have to sit. And that's because of psychology. This is actually the hardest skill to be a patient for. Most people don't realize that. You know, when we're playing around and we're practicing and we're playing at home and all that, and we're feeding somebody ice cream, it's all fun and games. But when somebody has to feed you for real, you are very aware that they hold your life in their hands. That changes the power dynamic. I mean, seriously changes the power dynamic. If you can't feed yourself, if I'm sitting in this chair and I can't feed myself and you come in and drop the tray off over there and I can't get to it and I can smell the food, I can see the food, but I can't eat the food, and then you don't feed me and you write down that I refuse the food, that happens. It happens. It should not happen. But that patient is dependent on you. And that changes the power. Does that make sense? If you stand over somebody to feed them, there's already a power dynamic, a power instability. When you stand over them, it puts them in a further dependent position. Does that make sense? Because of psychology, you have to sit to be on equal footing with them. If you stand, they feel rushed. They feel like they're an inconvenience. And a lot of times they just won't eat very well. Or they may react in anger because they feel that instability. Does that make sense? So you need to have a seat. You really do want to try to convince them that you want to be there. That's where that conversation comes in. If you spend your entire time feeding somebody like this while you're watching TV, that tells them that they're not a priority. Okay. So there's a lot of psychology that goes on into this, and let me explain why. Eating is the very first skill you become independent at. You learn how to hold a bottle way before you sit, stand, crawl, or walk. You pick up food off of a high chair tray way before you even know what hungry is. You learn how to feed yourself early in life. When you lose the ability to feed yourself, it affects you psychologically, profoundly. Patients that have to be fed usually suffer from a failure to thrive. We can help with that by making them feel like they're important and that we want to be there feeding them. You never want to treat somebody like they're insignificant when you're feeding them. Does that make sense? The act of feeding, super easy. You put food on a spoon and you get it into their mouth. You can all do that. I've got faith in you. That's not a hard skill. Making the patient feel cared about is the important part of this skill. Good. Years ago, we had a patient in the nursing home. She had to be fed, and she had dementia, but not debilitating dementia. She had had a stroke as well, so she couldn't feed herself, and she wasn't the easiest patient in the world to deal with. She had a lot of things going on, and it affected her. She was a little angry. Understandable. She's a little sad. Understandable. But she started dropping weight, like significantly dropping weight. And I'm starting to think maybe she's got something medically going on, you know? So I was walking by the room one day, and the CNA that was feeding her was standing beside the bed, shoveling food into her mouth quickly, complaining that she had 6 other people to feed and Miss Mary needed to hurry up. So I immediately said, why don't you go take care of one of the other patients? I'm going to work with Miss Mary today. And I pulled up a chair and I said, oh, Miss Mary, I've got to get off of my feet. I am tired today. Eat slow, please. Give me an excuse to stick around a little while longer. She ate that entire tray. Now, the last few weeks previous to that, she had eaten less than 25% of each meal. That's why she was dropping weight. Why do you think she was eating so little?
Because she was getting rushed.
She was getting rushed. Yep. What we do, guys, matters. But what matters even more is the way we do it. Does that make sense? All right. So this is a skill that doesn't follow all of our normal rules. There are some differences. Okay. We want to make sure this patient is sitting upright. And for the test, you can just ask them, hey, can you sit up straight? Super easy. But in a clinical setting, do whatever you need to do, whether it's propping the patient up with pillows, helping them sit up straight, putting the head of the bed up, whatever needs to be done, make sure they're sitting up straight. We don't want this patient to aspirate. Remember, aspirate is breathing in food or fluid. We're going to offer a hand wipe before we feed them. Now, I know I'm feeding them. Why am I giving them a hand wipe? 2 reasons. First of all, it doesn't say she can't use her hands. It just says she's unable to feed herself. So if food starts to drip and she can move her hands, you know where those hands are going to go? Yep, right up to her face. We have holes on our face. What do we know about those holes? Pathogens. So do we want unclean hands up near the face? Hand wipe. Get those hands clean just in case they should roam. The second reason that I want you to offer a hand wipe is because of ritual. Most people wash their hands before they eat. If you don't, you should. So hand wipe helps with that ritual. And I'll give you a story about this. I was recently on a cruise ship. Took a cruise. Had a fantastic time. I'm a cruiser. I'm a serial cruiser. I'm a cruise addict.
I've never been on one.
Oh, I love cruising. Love cruising. Well, we were on one of the newer ships, Carnival's newer ship. It was out of Miami. Had a fantastic time. Absolutely loved it. But what I really liked about this ship, because it was a newer ship, is at every single eating place, didn't matter where it was on the ship, they had hand washing stations, like actual sinks with running water, soap, paper towels, the whole 9 yards. So if I'm, out at the pool or whatever, and I go to get something to eat, there's a place for me to wash my hands. I don't have to go into the bathroom. Super convenient. Awesome. Because I know on a cruise ship, like a hospital, everybody brought their own pathogens with them, right? Not a very safe place from a pathogen point of view. I can stack the odds in my favor by washing my hands if I'm going to put them up next to any of my holes, right? So I am thrilled about these hand washing stations. In the entire cruise, I counted, by the way, the entire cruise, we only saw 3 other people wash their hands at these hand washing stations. 3. There were over 5,000 people on that ship.
It's crazy.
So if you don't wash your hands before you eat, you should. Okay.
I didn't just wash my hands.
So that's why we offer a hand wipe to our patients, because it helps with cleanliness, but it also helps with that ritual. Good? Make sense? All right. Oh, we're also going to offer a clothing protector.
Not a bib.
We don't call it a bib. Very good. Why don't we call it a bib? Sure. So we offer a clothing protector, which is just a towel, right? Yeah, we're going to talk about that in the next skill. Absolutely. So we're going to offer clothing. They can say no. It's okay. My grandmother, very prim and proper. Let me tell you, you did not treat her like a child. You offer her a clothing protector and she'll sit up straight and go, I don't need that. I am not a child. So no problem. Offer it. She says no. I move on with my life. Me, I need a clothing protector. I wear everything I eat. You offer me a clothing protector, I'm going to say, yes, please. Okay. Everybody's different. We're going to offer. Okay. Good. Oh, yeah. I wear everything. When we feed our patient, we're going to sit and face them. Not the TV, not anything. We're going to face them. Who should be our focus while we're feeding? Patient. Do not pull your phone out and go through Snapchat. We're going to offer a drink before feeding and every 2 or 3 bites. Okay. They may drink, they may not. Everybody's different. Everybody has different eating preferences. We don't really stop and think about this, but we do. And I'm going to prove it to you. My aunt drank an entire glass of water before she ate any meal. Did it her whole life. And that was so she filled up on water and there was not much room for food. It's how she kept her figure. It worked for her. It doesn't work for me. Worked for her. Some people drink with a meal. That's me. I have to drink as I eat because I don't produce a lot of saliva and I need that extra liquid, for things to work right. So I drink while I eat. My husband does not drink at all while he eats. He drinks after he eats. Everybody is different, right? But you guys all have eating preferences that you probably aren't even aware of. So we're going to go through this real quick. How many of you eat all of one thing before you move on to the next thing on your plate? Okay. Yep. So some people eat a little of this, a little of that. right? Some people eat all of one thing before they move on. Okay. Yep. So some of you like corn and mashed potatoes mixed. Some people don't like their foods to touch. Absolutely. Absolutely. Some people eat salad first. Some people eat salad last. Just because it's the way you eat doesn't mean it's the way your patient eats. If you are a mix the corn and potatoes person and your patient is a don't let my foods touch patient, they're not going to eat that corn and mashed potatoes that you mix. Make sense? But let me tell you the absolutely worst story with this. This was horrible. I was in hospice. This was not too terribly long ago. I was in hospice, went to a local nursing home. Patients are all in the dining room. This is a patient who had terminal cancer. She'd also had a stroke and was nonverbal. So she's in the dining room and a CNA is feeding her. There's 3 patients at the table and the CNA, so 4 of them sitting around the table. The CNA is feeding each one of them. And I come in and I look and she's got this gray gloop in front. That's the only way I can describe it. Is this big pile of gray goop right in front of them. And I'm like, oh. And her name actually was Miss Mary. So I said, Miss Mary, what are you eating? And she was nonverbal, but still very expressive. So she kind of looked up, rolled her eyes, and turned her head away. Very obvious that she did not like this gray goop that was in front of her. And I asked the CNA, I said, what is for lunch today? And she says, oh, I think it's Salisbury steak, mashed potatoes, and beets. And I said, okay, but what is that? And she said, whatever's for lunch. I just always mix it all together. And I said, would you eat Salisbury steak, mashed potatoes, and beets mixed? She says, no, that's gross. Exhibit A. You just did that. She says, oh, no, you're mistaken. It's pureed. There's no taste to it. And I said, oh, no, you're mistaken. Pureed is all the taste, none of the texture. Yeah. All the taste is still there. Oh, my goodness. It's just that we puree it so they don't have to chew it. Would you eat Salisbury steak and beets mixed? And she said, no. Then don't do it to your patients. Go get new trays. Don't make assumptions. She legitimately thought pureed meant bland. It does not. So be careful about your assumptions because your patients are the ones that are going to pay the price for it. Well, she had been doing this for a year, mixing everything that was pureed. And guys, there are some things that really should not be mixed. And then she wondered why her patients didn't eat very well. She just figured it was because they were feeds. No, they didn't eat because they didn't like what you were feeding them. So we have to be a little mindful of what we do when it comes to that. Does that make sense? Okay. Remember, pureed does not mean no taste. Please remember that. All right. We're going to feed slowly. We're going to fill the spoon halfway full. Now, for the test, if you're the patient, let's say that you're the patient, they're going to sit you down in a chair, tell you to slump or slouch, but they're also going to tell you to only take 4 bites of food. That's it. After 4 bites, you're going to tell them, I'm done, I'm finished, whatever. You're just no more. Okay, 4 bites. Well, remember that we have to offer a drink before and every 2 to 3 bites. So if we get to 4 and you didn't offer a drink, you're not going to get that checkpoint. Got it? So all I need to see is 4 bites. So we're not going to overload the spoon, less than half full. So remember, if you don't like pudding or applesauce, you're only eating 4 half spoonfuls. Okay, you can choke that down, right? Good. Okay. All right. And you're going to have a conversation. I don't care what that conversation is. Nobody does. Encourage intake if the patient doesn't eat well. At the end, when she says, I'm done, I'm finished, I don't want any more, I'm full, whatever she says after 4 bites, she ends the skill. I am not going to go, thank God, I got a million things to do, I'm out. That's not how I'm going to end this. I need to encourage her at least 2 different ways to continue eating. The first thing I'm going to do is turn up the sweet. Because remember, you can always get further with patients by being nice than being nasty. So I'm going to say, are you sure you don't want just one more bite for me? Come on, just one more. Patients have a hard time saying no when you're super sweet. So she'll probably take one more bite just for me. If she says, no, really, I don't want it, I'm going to offer to get her something else. We've all had these days where you want something, you go make it or go buy it, you take a bite and you're like, nope, not it. Not it. That wasn't what I wanted. Thought it was, but it wasn't what I wanted. Yep. So maybe this patient is having that same issue. Had a couple bites, not really what I wanted. So I'm going to offer to get something else. Can I get you something else from the kitchen? Would you like something different? Maybe a sandwich or something. The last thing I'm going to do is to let them know if they get hungry later, food is available. So they never have to worry about going without food if they're hungry. I always use all 3. You need to use at least 2. Are you sure you don't want just one more bite? Can I get you something else? If you get hungry later, let me know. Okay. You need to use at least 2. That lets the patient know that you seriously care about their nutrition, that this isn't just something you're trying to rush through. Good. Okay. All right. We'll leave the area around the mouth clean and we're going to do our closing. So this is not a hard skill. It's not a long skill. It's pretty easy overall. But we do have to document. This is a documentation skill. They give you 9 minutes to do this skill. It does not take 9 minutes to give 4 spoonfuls to somebody. It's not a long skill. But we are going to have to document. Now, remember in your book on page 168 are the documentation forms. And the one we're going to use is actually the first one on page 169. You can see a small version of it back on the skills page on page 109. And the first thing it asks us is, what are we feeding the patient, a snack or a meal? Well, what does our care plan say? Snack. And then it's going to ask us to estimate the percentage that the patient ate. Now, remember, we're only giving 4 half spoonfuls. This is going to be on a quarter scale. We're going to get to documentation in just a minute. So here's our details. We want to offer a hand wipe before feeding, offer a clothing protector, offer a drink before feeding, and every 2 or 3 bites, we'll let them leave. We're going to feed slow, spoon only half full, and don't use planes, trains, or automobiles. Okay, no. We want to treat them like adults. Now, I'm going to tell you in my career, I use a lot of humor, and there are patients that I do play around with. But I have to get to know the patient a little bit before that, because if I did that to my grandmother, I'd probably end up across the room. Okay. So we have to know, we have to be able to read our patients a bit. So for the test, do we know our patients?
No.
Are we going to use this? No. Okay.
This is a silly question. What if they refuse to eat? Because I've seen some CNAs shove the food in their mouth.
Oh my goodness.
They can chew in their mouth and be like, that's not okay. But is there other ways?
Do patients have the right to refuse?
Yes.
What are we supposed to do when a patient refuses? Tell the nurse. Yeah. We don't force anybody to eat anything. And if you are, if you do force the patient, there's a couple of things that can happen there. Number one, we can actually break their teeth by forcing a spoon in. We can also cause them to aspirate or breathe in because they're not expecting the food there. And in some cases, we're forcing them to eat something that they don't want or like.
Or even can have
or even can have. And I'll give you a good example of this. Now, this is probably not something that you guys would think about in a normal thing, but if we have a Jewish patient who is keeping kosher, okay, their food has to be prepared and served a certain way. If they're in a facility and they're not sure if their food is indeed kosher, do you think they're going to eat it?
No.
So they're going to refuse. If you shove that food into them, you are not just violating their right to refuse. You're also violating their religion, and that can have serious implications because they are eating food that is unblessed, unholy, unspiritually good. And that can be very, very detrimental. That actually happened in a facility I was in.
This was in MSU, memory loss.
Memory care.
Yeah. So
We don't force.
I mean, you can try later, like come back.
Right.
Faces. If they refuse, just tell the nurse.
We're going to let the nurse know. And it's very common in stage dementia to not know what food is or what you're supposed to do with it. So refusing is actually pretty common in in memory care units, especially in end stage dementia. But there are strategies we can use, like finger foods. We can do protein shakes with an additional scoop of protein in, because a lot of times, even if they won't eat, they will drink. So there are strategies that can be used, but who's the one that needs to develop those strategies?
The nurse.
So if the nurse doesn't know that the patient is refusing, then that situation isn't going to get resolved, right? So no, forcing a patient to eat is never appropriate. Never. We've got to find another way around it. I'll give you a great example. There was a woman. This is when I was doing hospice. This was down the next county down, and she has stayed with me for 20 years. I fell in love with her. She was just a sweet, sweet woman. Totally nonverbal. She was dementia. She had end stage ovarian cancer. She could not sit. Sitting was painful, because she had a lot of abdominal pressure. And of course, she's got dementia. She doesn't really understand what's happening. She walked nonstop, walked. She would go lay down for about 2 hours a night, and then she'd be back up walking. Walk, walk, walk. She did not eat. She didn't know what food was. It had no, she wouldn't sit down to eat. So we gave her little finger snacks and we worked to try to find something she liked. Well, it turned out she really liked cheese. She really liked cheese. So every time she'd walk by the nurse's station, somebody would hand her a little cube of cheese and she'd eat it as she was walking. And that was a way of getting food into her. But what I found was that she really liked Wendy's Frosties. I mean, she really liked. So every day that I went to the facility, I went through Wendy's and bought a Frosty and brought it into her, because it was the only way. I mixed a little protein powder in there to boost the protein. It's the only way that we could get nutrition into her.
Sometimes you have to do an extra step for your patients.
Sure, absolutely, absolutely. Now, she was terminal. Could I have just said, "Oh, well, she's dying. Who cares"?
That would have been wrong.
Yeah, I could have, but is that ethically right? No. And I'm always trying to be the kind of nurse that I would want. So forcing somebody to eat, yeah, we could have shoved a spoon in her mouth, but that isn't going to help her. It might provide nutrition, but it's not helping her. We got to find a better way, and that's what the nurses are there to do. Okay?
So, like you brought like a Frosty, will every facility allow you to do that? Or
No.
Really,
No.
You just had a good facility that.
Well, I was the hospice nurse, and I would go place to place, so it was no problem for me. Yeah, it was no problem for me to go through Wendy's because it was near the facility. So I would just go through, grab a Frosty, take it in, and she would be the first patient I saw. And I would walk with her as I'm feeding her. And I would spend 30 minutes. We'd walk around the facility, and I would feed her a
Just
little
to
bit of
think how much
frosty.
that meant to her. Like that probably meant the world to her.
Yeah.
Just because she knew that she was eating that day.
Yeah, for me, it was very special because she had no family. She had nobody visiting her. She was all alone. And yeah, she's got dementia. I may not have even been a blip on her radar, right? But it doesn't matter.
But she was on yours.
She was on mine. Yeah.
Oh,
You're
something.
oh, it just needs a little. Oh.
Trinity.
Oh no.
Oh. Hey, can you go tell Trinity that she's airplaying on my TV?
Oh, is that one of your workers?
Yes.
She is fermenting. Oh.
I hope she don't go too far.
I know.
Is this on her phone or is this you? That's
Oh,
you.
she's got
Okay.
It's like, oh, we're just gonna watch it.
There we go. Yeah, I'm not sure what she's streaming, but not to my TV, please. All right. So let's talk about percentages now. Most of the time when we're documenting food intake, it's going to be on what we call a quarter scale. So at the two ends, you got 0. That means they didn't eat anything. And you got 100%, which means they ate everything. Okay. And then in between is our quarter scale. So 25% means they barely touched it. They took a couple bites. We call them, well, my granddaughter would call them no thank you bites. She's not allowed to refuse anything. She has to take a no thank you bite. Yeah. And that way it gets her to try new things. Okay. So I call that the no thank you bite. Okay. A couple bites. 50%, they ate half, roughly. It's not exact. We're not like measuring crumbs here, right? It's an estimation quarter scale. 75, they ate most of it, but not all. They're not a clean plate club member. Okay. So if we look at this, you have to know what you started with to know how much the patient ate. So this plate, we've got a sandwich, some broccoli, and some Jell-O. That does not sound like a good lunch, but let's go with it. Sandwich, broccoli, Jell-O. If we look at this, they ate maybe 1 or 2 stalks of broccoli. They ate a bite of their sandwich. They ate a couple cubes of Jell-O. Out of this, how much would you say that they ate there? Yeah, they took a couple no thank you bites. That was it. Okay. If you look at this, half the sandwich is gone, half the broccoli is gone, probably some of the Jell-O is gone. What would you estimate that at? 50%. So this, almost everything is gone, but we did leave a few things. 75 here. 100. Yeah. Nobody eats these things, right? The stalks. Okay. So it doesn't have to be 100%. It's much closer to 100 than it is to 75. Okay. So this is an estimation. Now for the test, we're going to have to estimate how much of this Jell-O or pudding or applesauce or pudding that our patient ate. Remember, you're only giving them 4 half spoonfuls. Yeah, 25%. Good. Now, fluids, we would also estimate on a quarter scale as well. If they don't drink it all, it's 0. If they drank all of it, it's 100. If they took a couple sips, 25. If they drank half, 50. If they drank most, 75. So you're going to do the same thing with liquids for the test. But in a clinical setting, liquids are evaluated much differently. In a clinical setting, we convert liquids to actual numbers rather than percentages. So for the test, we're going to use a percentage, but in a clinical setting, we're going to use hard numbers. And in medicine, we use cc's, also called mLs. Cc's and mLs are the same thing, 2 names, same thing. Cc's or mLs, each ounce is worth 30 cc's. Each ounce is worth 30 cc's. So if we have 8 ounces of water, we multiply 8 ounces by 30 cc's, and that gives us, what's 8 times 30? 240. If we have 6 ounces of coffee, we multiply 6 by 30, and that gives us 180. So we do the conversions as CNAs. You have to know how to do this math. You multiply the amount of ounces by 30 to get the amount of cc's. Remember, cc's and ml's are the same thing. But sometimes our packaging actually does the conversion for us. So your Starbucks double shot, look at the bottom of it, bottom of your can. It'll tell you, is that 12 ounces? 15 ounces? Right next to it, it has mLs. How many mLs? Okay, so it tells you right on the can, 12 ounces or 443. Or 15 ounces, I'm sorry, or 443. If you look at that bottle, that water bottle right there, it'll tell you how many ounces. Can you look on the label? 16.9. Right next to it, it has mLs. 500 mLs. So yours, somebody had one over here too. Oh, yours. Okay. Your bottle. How many ounces? 14 ounces. And how many mLs? Okay. So if the label gives you the mLs, we're going to use that. Okay. So 443, 500, and 414. We would use those numbers. If we just had a cup, so that is a 24-ounce cup, we would multiply, because it doesn't tell us how many mLs, we would have to multiply 24 by 30. Okay? Does that make sense? Good? Okay. So in your book on page 106, I have a whole lesson on this that allows you to practice doing that conversion and practice estimating the amount of food and fluid. The answers are in the very back of your book, and you can do this on your own. I also have a lesson in the online course that has a whole lot more of these to help you get that practice in for it. And your review sheet for today will also have a few. Go to page 132, though, if you would. And 132 of your book shows you some medical abbreviations. About 3/4 of the way down the first column, you'll see NPO. NPO means nothing by mouth. And this really confuses students because how in the world does NPO, how in the world do those initials mean nothing by mouth? Well, it's because the initials are abbreviated Latin, not abbreviated English. Latin is the language of medicine, science. Everything in science is based on Latin. So NPO is Latin for nothing by mouth. Good. Everything on this page that is shaded in gray are ones that you probably want to make sure that you know, because those are the ones that are going to come up in clinical, and you won't have them on the test. Nobody's going to ask you on the test, what does NPO mean? But they're ones that you're going to need to know to perform your job properly. So I would pay attention to those. And then there's on page 133, there's a whole activity where you can put those abbreviations into use, and you can see how they would be used. So that's an activity for you. And we've already been over documentation. So page 107 talks to you about intake and output, and that's what we would need those measurements for. When our patient is on intake and output documentation, it means that we are measuring everything that goes into the patient and everything that comes out of the patient. They should be roughly equal, within about 100 cc's, roughly equal. If we're putting stuff into the patient and it's not coming out, that's a problem. It's going somewhere. We got to figure out where it's going because it doesn't belong there. If we're putting stuff if we're putting stuff into the patient, but way more is coming out of the patient, oh, that's a problem. Okay, that means patient could get dehydrated unless we're trying to cause that. So when we have patients on intake and output measurements, we're going to keep track of everything that goes in and everything that comes out because it tells us a little bit about our patients. That's when you would have to do those conversions. Okay. But at the end of the shift, you have to add it all up. If I tell you, if you go back to page 106, if you look at the bottom of the second column, if I tell you during the shift, the patient had 6 ounces of juice, 8 ounces of milk, and 12 ounces of coffee, how much was their intake for this shift? You would have to convert those to cc's and then add them all up together. That's how we get total intake for the shift. You do the conversion to cc's and then you add those all up to find out how much intake the patient had for the shift. You will have one math question on the written exam. It will either be converting from ounces to cc's, or it will give you a whole bunch of cc's and ask you to add them together to get the total intake. You will have a math question on the state exam.
So when you do that one, there's no calculators, so you have to do it like
No calculators, but they're going to give you scratch paper or a whiteboard. So if we have a 6-ounce cup of juice, how many cc's would that be? 6 times 30. 180. Yep, 180. Our milk carton, if you look at that milk carton, it tells you how many cc's. So how many? 240. Remember, I said if it tells you, we believe it. If we have 12 ounces of coffee, man, I need about 12 ounces of coffee right now. We have 12 ounces of coffee, 12 times 30, 360. So if we add 180 plus 240 plus 360 together, we would get the total intake.
Are we allowed to like the test? Oh, it's not written, right? Or is it on the test?
It's on the computer.
Are we gonna have scrap paper?
Yeah, or a whiteboard.
Okay.
Scrap paper or a whiteboard.
I gotta go back to like 2nd grade over here.
Did anybody do that math for me? 780. Yep. 780 is right. If you add 240, guys, the easiest way to do it, you got 240 and 360. We know 40 and 60 makes 100, right?
Yeah.
So I always look for endings that make 100.
That's what I was trying to do.
Yeah. So 240 and 360 makes 600, and then you add 180 to that, makes it 780.
So I'm dyslexic, so I have this issue. Obviously, I have an issue where I move numbers
Right.
around, but it's like the only way that I can figure it out is where I have to be like, okay, 6 times 3, and then add a 0.
Right.
And that's the only.
And that's perfect. That's actually the way I do it in my head. That's the way I do it in my head. Yeah.
That's how I figured out the 12 ounces. I just did 3
Yeah.
times 12 and added a 0.
And add a 0. Yeah. Yeah. So everybody okay with that? It's not an automatic fail. If you get the math question wrong, you don't automatically fail. It's okay. But it's kind of important in a clinical setting, do you think? Yeah. So we probably want to know how to do this. And in a clinical setting, you can always pull your phone out and use your calculator. All right, so let me show you this video. I do not have anything to feed anybody, so we're going to do this one by video.
Hello?
Hi, Mr. Jones. My name is Patty. I'm your CNA today. Would you like a snack?
Yes, please.
Okay, I'm going to go wash my hands, get my supplies, and I'll be right back. Can I ask you to sit up straight for me, please?
Okay.
Thank you. Okay, Mr. Jones, let me get you a hand wipe so that you can wipe your hands. Would you like to take that? Thank you very much. Let me dispose of this. Okay, can I offer you a clothing protector?
Yes, please.
I'll just place this on your chest. Okay, it looks like we have pudding. How does that sound?
Great.
Very good. Can I offer you a drink before we get started?
Please. Thank you.
You're welcome. Okay, are you ready?
Yes.
There you go. Do you have any plans for this afternoon?
No, I do not.
They're showing a movie on the big screen in the activity room. Would you like me to get more information on that for you?
Yes, please.
Okay. How does the pudding taste?
Delicious.
Very good. Ready for another?
Yes, please.
Okay. Can I offer you a drink? Would you like something to drink?
Yes, please.
All right. Ready for another bite?
Yes, please.
Ready for another bite?
I'm actually full.
Are you sure you wouldn't like just one more bite?
I'm okay, thank you.
Can I get you something else from the kitchen?
No, thank you.
Okay. Let me know if you get hungry later, and we'll get something to eat. We do have food available on the unit.
Thank you.
Going to take the napkin. There we go. I'll remove this clothing protector from you, and we're going to put this in dirty linen. I'm going to go take care of your tray. I'll be right back.
Okay, thank you.
Okay, I'm going to place the tray back on your table. Is there anything else I can get for you? A magazine, perhaps?
No, thank you.
Your call light is within reach. Please let me know if you should need anything. I'm going to go wash my hands and document.
Okay, thank you.
After washing my hands, I'm going to document the amount of food that this patient ate. Using my documentation form, I'll review the steps of my skill, make any corrections, and tell the evaluator my skill is done. All right. Any questions?
I have one quick question.
Yes.
Do we not use gloves even though we're next to their mouth?
Okay, that's a very good question. And the answer is it depends on your care plan. Now, there's a reason for that. First of all, you're on the other end of a spoon. Okay, so we're not actually coming into contact with their body fluids.
Okay.
So our rules aren't really triggered, right? Because we're not coming into contact with the body fluids. But here's the thing. Gloves give off an odor. That odor is actually an appetite suppressant.
Yeah. Okay.
So if you're wearing gloves routinely when you're feeding somebody, it will kill their appetite. The other problem is, remember, they're already going to have a hard time emotionally with this, with being fed. When you put gloves on to feed somebody, it just
doesn't make it feel great.
Yeah, it's not really a cared about type of thing.
Okay.
Okay.
Why was there no privacy curtain?
Because eating is a social event, and if you close the privacy curtain, it isolates them and they don't eat very well. Okay, good. Any other questions? Moving on. We are going to learn about Pericare, page 153. So 152 shows you the principles involved, and man, there are a lot of principles for this skill. We're going to follow the care plan. We're going to start with the opening. We'll evaluate gloves. Yes, you need them. We're in the patient's peri area. Peri is personal. We're going to use a barrier because we have supplies. Our patient's uncovered, so we need a privacy blanket. We're going to use linen, so all the linen rules apply. We got to turn them on their side, so we're going to scoot them toward us first. Washing rules, basin cleaning, closing. Oh my goodness, there's a lot going on with this skill. It is a long skill. but it's not a hard one. You already know all the steps. I'm going to show you along the way. We're actually going to talk about this one step by step as we go through the skill, and then I'll show you the actual skill. But we have to understand a little bit about what incontinence is. So if we look at the top of page 153 and read our care plan, it tells us the female patient has been incontinent of urine and needs perineal care. The pad under the resident is wet, but the hospital gown and bedding is dry. The page before, if you look at the bottom, you'll see this is going to be done on a mannequin. Thank God. Okay. And it's giving you 17 minutes to perform this skill. It's a longer skill. Remember, partial bath was 19 minutes. They're giving you 17. So still a long skill, but it's just a bathing skill. That's all we're doing is bathing. But we got a lot of steps involved in that bathing. So let's go through that. In order to learn this skill, we have to learn what incontinence is. And incontinence is simply an inability to hold urine. That's all it means. You can also have bowel incontinence, which is an inability to hold feces. If we can't hold it, that means it's going to come out willy-nilly, right? But let me explain to you how and why, because this is important that you understand this. This is a normally functioning urinary system. You learned this in 5th grade. You may not remember it, but you did. In your body, you've got 2 kidneys. Those kidneys filter blood 24 hours a day and remove waste products. Those waste products go down tubes called ureters and collect in the bladder. Okay? Kidneys work 24 hours a day. They don't take coffee breaks. They don't take vacations. There's no time off for good behavior. They work 24 hours a day. So your kidneys are always filtering blood and creating urine. That urine drips, 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 drips into the bladder. Your bladder is nothing more than a Ziploc bag. That's all it does. It just holds liquid. Now, at the bottom of the bladder is a little valve. That valve, as long as it's closed, keeps the urine in the bladder until you go to the bathroom. And then you open the valve, and the urine comes out through the urethra into the toilet. When you're done, the valve closes, and now you can store urine until your next bathroom trip. Make sense? Everybody good with this? All right. So that's a normally functioning urinary system. But when we have incontinence, the part of the system that isn't working is the valve. Kidneys still filter blood, produce your urine 24 hours a day. Drip, drip, drip. Those drips still fall down tubes into the bladder. Drip, 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 drip. But the problem is that because that valve isn't working, it doesn't stay in the bladder. Where do those drips go?
Just right out there.
Out. Into the wide open. So if we have kidneys that are filtering blood and creating urine 24 hours a day, drip, 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 and there's nothing in the body to keep that urine in the body, that patient is going to be wet 24 hours a day. Drip, 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 drip. Good? Make sense? If you've got a patient that's dry, 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 really, really wet, you do not have an incontinent patient. You have incompetent staff members that aren't getting that patient to the toilet. That's what you have. Incontinent patients are going to be wet 24 hours a day. The problem is that adult urine is not like baby urine. Because part of the waste products that the kidneys filter out is acid, extra acid from what we eat and drink. Now, adult diets, very acidic. Most of what you eat and drink has a lot of acid in it. Baby diets are not that way. Baby diets are very bland. You know, formula, rice cereal, breast milk, very bland. Not a lot of acid. So their urine is much milder, much more normal pH. Adult urine, acid. What happens when you hold acid against skin? It burns. So when we have an adult patient who's incontinent, that means that we need to be aware it may burn the skin if we leave that urine against the skin for a long period. Good? Make sense? Okay, adult briefs. We don't call them diapers because these are adults, not children. Adult briefs are often put on incontinent patients when they're out of bed. That's a dignity issue. Nobody wants to wet themselves in public. So that's a dignity issue. So out of bed, they usually are in adult briefs. That's going to hold the urine right up next to the skin. It also blocks out light and air, and holds in body heat. Warm, dark, moist. What grows there? Pathogens. This is not ideal, is it? No. Now we use them when the patient's out of bed, dignity, but they still have to be changed every 2 hours around the clock, and the skin needs to be clean because remember, acid. Okay, good.
So even when like they're in bed and they're wetting themselves, it's still every 2 hours.
Every 2 hours around the clock. Yep, we're going to get there now. So every 2 hours around the clock. So if they're out of bed with an adult brief, we're going to change that brief and clean them up every 2 hours around the clock. If they're in bed, we're going to clean them up every 2 hours around the clock. And some patients in bed will still be wearing adult briefs because they like that security. But that adult brief, remember, warm, dark, moist inside. There is a better way. If the patient agrees, we will leave the patient open to air. That means they're on a pad, a chucks, a bed pad, and that's going to draw the urine away from the skin. It will also allow air and light to circulate, and it cuts down on the amount of pathogens in the area. So a lot of your patients will be open to air in bed. Does that make sense? So that means they're on a pad that's collecting the urine. But they still have to be cleaned and changed every 2 hours around the clock. So we kind of need to know by our care plan, is our patient going to be in an adult brief or open to air on a pad? Good. This care plan tells us our patient is laying on a wet pad. So we know they're open to air. Good? Questions? Let's think about that pad for a second, though. It's going to pull the urine away from the skin. Now, what do we know about room temperature? Room temperature always wins, right? So if we have urine that is made up in our furnace area of our body, that urine's actually just a little bit warmer than body temperature. Body temperature is 98.6 degrees. Urine's about 100, 101 degrees. A little bit warmer because it's up in our furnace area. So when that urine comes out, it's about 100, 101 degrees. It hits that pad, spreads out, and it comes into contact with air. We know room temperature always. So that temperature of that urine is going to fall to room temperature. What is that pad going to feel like to your patient? Cold, wet, and probably a little slimy. If you were on that pad, what would you want done? Changed right away. So this skill requires that we change the pad immediately, right away first. But we got a wet butt on a clean pad. So we're going to clean the front of the patient, we're going to clean the back of the patient, and then we're going to put a brand new pad under the patient. So we have a dry butt on a dry pad. So this skill requires 2 chucks change. The first one for comfort, the second one for the next 2 hours. Good? Questions? So we're going to change that pad first. Now, we're going to use our washing rules. We already know these rules. We're not going to add soap to the... We're going to use a paper towel to turn the faucet on. We're going to check the water. It should feel... We're going to have the patient check the water. We're going to use our leaves method because we're in a wet body opening. Whatever we wash, whatever rinse, and we're going to keep our surface. Okay. So we're not using lotion, so we don't have to worry about that. Okay. But all of our washing rules exist. Okay. So we already know all of these. You just told me all of these steps, right? All of these steps we've already mastered. So when we're looking at our checklist, let me find it. Hold on. Okay. So this is our checklist with all of our colored principles, right? So if you look at this, anything that is white is not covered under our principles. Okay. So when I show you this, I want you to look at how many squares are white. That's what I want you to focus on, not colored in. So take a look. Not very many, right? Most of these checkpoints have a colored square in front of them, don't they? That means that this is what they're grading you on. This is the checklist. If you know skill rules, the opening, glove rules, barrier, privacy blanket, linen rules, scoot and roll, washing rules, basin cleaning, shoe rules, and the closing, well, that's pretty much this entire checklist. So for this skill, we are only going to learn 1, 2, 3, 4, 5, 6, 7, 8, 9 things. That's it. You know everything. There's a lot of steps here. There's a lot of check marks here, but you only have to learn 9. You know the rest. Okay, good. It is cold in here. Penguins are marching. Okay, let me turn that off. Okay. So to refresh your memory, our care plan says the female patient has been incontinent of urine and needs pericare. Pad under the resident is wet, but the hospital gown and bedding is dry. So the steps that we're going to do that aren't covered by all of our principles, we're going to change that chucks out. Well, we know why. It's cold, wet, and slimy. We're going to use the leaves method. Well, we know that, right? It's a wet body opening. We're always going to clean from front to back. We're going to talk about why. We're going to clean down the middle, the outer labia, and then the skin folds. We're never going to move back up. We're going to turn the patient onto their side using scoot and roll. And we're going to clean the backside. Change that chucks again. Those are the important steps for this skill that you don't know yet. None of them are very hard, are they? Well, let's learn why. We're just going to skip right through these because you already know all these. I don't need to review this. Okay. So the first thing we want to do is change that chucks out to get our patient on a clean chucks. And then we're going to roll the blanket and place a towel over their legs. Now, this is kind of important. I know I have to expose my patient because I'm working in that area. I got to be able to see what I'm doing, right? But there is a big difference between pulling the sheet down, pulling the gown up, and having the patient out there, and having their legs covered with a towel and their body covered with a blanket. So the only thing that's showing is the part I'm working on. Which one do you think the patient is more comfortable with? The second one. So that's why we want to roll that blanket up and put a towel over the legs. That way we're minimizing exposure and it makes it more clinical for the patient, a little less icky. Okay. So we're going to cover the thighs to minimize exposure. We'll wring our washcloth out and we're going to wash top to bottom. Always top to bottom. We're going to go down the middle. We're going to go on the outside, top to bottom, the other outside, top to bottom, the skin fold between the leg and the groin, top to bottom, and the other skin fold. So we need 5 leaves for this. So if I have my washcloth and I wring it out, remember, no drippy wet washcloths, and I put it in my hand, holding it the right way, and I soap all 5 corners. So soap, 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 soap. I'm ready to clean. I'm now going to take this washcloth and go top to bottom, pull away, and fold it over. Do not do this. Top to bottom, back up. Okay? We don't want to bring bacteria from here. We have bacteria in our anal area. We don't want to bring it up to the urethra. Remember our graphic that we saw a minute ago? The urethra is a direct line to the inside. And ladies, your urethra is only as long as your pinky. That's not far for a bacteria to travel. That's like a day trip. Not far. So when we clean, we hold our washcloth, we start at the top and go down, out, and then fold. Now I'm going to go down the outside, fold it, the other outside, fold it. Whoops, back here. The skin fold it, the other skin fold. And then I'm going to set this aside because it has soap on it. I'm going to get my second washcloth, wring it out, no soap, because now I'm going to rinse. Hold it the same way. I'm going to rinse top to bottom, fold that over. One side, fold that over. The other side, fold that over. Skin fold that over. Skin fold. Questions? Okay. So whatever we wash, we rinse the same way. Whatever we rinse, we dry. When we dry, we're going to start at the top and pat down to the bottom. Do we ever go back up? No. Now, male pericare is in your skills book. It's actually at, hold on, let me tell you. On page 154, talks about male pericare. Male pericare is not tested on the state exam. It's not on the state test. We're going to be doing this on female mannequins, not male mannequins. But male pericare is pretty simple. You wash what you see. Start at the top of the penis, you go down the shaft, you clean the scrotum. Whatever you wash, whatever you rinse, you dry. If the male is uncircumcised, you do have to retract the foreskin to clean under the foreskin, but we always put everything back where we found it. So put the foreskin back before you end the skill. Okay. All right. So we're going to wash, rinse, and dry the same way. Then we're going to cover our patient. We still have to wash the backside, right? They were laying on urine. We still have to wash the butt. But I don't want to leave my patient exposed while I'm doing that. So I'm going to pull that blanket down to cover my patient and then scoot and roll, and we're going to clean the butt. Now we're going to use the leaves method. So I'm going to take my washcloth, wring it out really well. I'm going to put soap on 4 leaves. So soap, fold, soap, fold, soap, fold, soap. I don't need the back side. You can soap it if you want to. Nobody cares. And then I'm going to take this washcloth and I'm going to clean the back side. I'm going to start at the anal opening and go right up the middle. It's kind of like a riverbed. That's where the urine is going to be channeled. I'm going to fold that over. I'm going to clean one cheek, fold that over, clean the other cheek, fold that over, and then once more up the middle because it's a riverbed. Now, I've got the patient on their side. I'm done washing. This is going to go on my barrier. I'm going to get a new washcloth, wring it out, no soap, and I'm going to rinse the same way I washed. So once up the middle, fold it over, one cheek, fold it over, the other cheek, fold it over, and up the middle. This will go on my table, on my barrier. Then I'm going to get my towel and dry all of those areas, same way. Good? Once I've washed, rinsed, and dried the back side, we're going to dry. I'm sorry, we're going to change the chucks out one more time. Okay. At the end of the skill, we'll return the patient to the center of the bed, make sure they're covered with a blanket, and then, we're going to dispose all of our linens.
So if the one's really wet, can you just like get like of course get one and change it right away so he's not.
That's what we're going to do. So we change the chucks to begin with.
Okay.
First, we clean the front, we clean the back, we change it again.
Okay, so there's 3 in total because you're
And then you got the
replacing 2.
barrier.
Okay.
Yep. Good. So we'll put all of our stuff away, clean our basin, remove our gloves, and then take the privacy blanket off. Remember, the blanket comes off after the gloves come off.
What if you come across that it's more than just you?
So for the test, it won't. In fact, for the test, there won't be anything. You're pretending it's wet. But in a clinical setting, you would use whatever washcloths you need to clean that area, but you're going to use the same process. You just may need a couple extra washcloths.
You can use the cloth for that too.
Yeah, now you'll go by your facility policy
Okay.
because some facilities will use washcloths to do that. And then they just get laundered with bleach. Some facilities will use wipes. It depends on your facility, how they're structured. So that's a good policy and procedure question. Okay. Some facilities charge patients a flat rate, and then all supplies are included. Other facilities, patients have to pay for their own supplies. So that's going to dictate how we proceed here. If the patients are paying for all their own supplies and they can't afford wipes, then the care plan may have us using washcloths. Wipes are expensive. Okay. All right, and then we'll finish up with our closing. So does that make sense to everybody? Okay, let me show you the video for this because it has really good close-ups. I can demonstrate this one on the mannequin, but it's a big class. You guys aren't going to be able to see everything effectively. So let me show you the video for this one. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Wonderful. I need to do Pericare. Is that okay? Okay, let me close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, I'm going to start out with a barrier. This gives me a clean place to place my clean supplies. So I'll place the barrier on the overbed table. And now I'll start gathering my supplies. I'm going to need 2 chucks, 4 washcloths, a privacy blanket, a towel. I'll place these items on the overbed table. I'll need a basin and soap. And I'm going to need a set of gloves. Okay, Miss Jones, let me go fill the basin. I'll use a paper towel to turn the water on. I'll make sure it's warm. Not hot, not cold, just warm. Miss Jones, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place my washcloths in the water. Okay, Miss Jones, I'm going to place this privacy blanket over you. This is going to help keep you warm and protect your privacy while we do this skill. I'm going to spread the blanket out, being careful not to shake it or snap it. And then I'm going to pull your sheet down to about your knees.
Now I'll get my chucks ready for use. I'm going to unfold the chucks, hold it up lengthwise, and roll it toward me. And I'll repeat that with the second one. Clean rolls toward me, dirty rolls away. Now I'll get my gloves on. Okay, Miss Jones, in just a moment, I'm going to ask you to scoot toward me, and we're going to roll you onto your left side so I can change the chucks that's under you. I'll place one of the chucks on the bed. Miss Jones, can you scoot toward me, please? Thank you, and roll up on your left side. 1, 2, 3. I'm going to roll the dirty chucks toward the patient, tuck it under her hip, unroll the clean one, and tuck it under the soiled. Miss Jones, can you roll back onto your back, please? Thank you, and scoot to the middle of the bed. Okay, I'll come around to the other side of the bed now. Miss Jones, can you scoot toward me, please? And roll up on your right side. 1, 2, 3. We'll remove the soiled chucks from the bed and unroll the clean one. This is going to be thrown away. Okay, Miss Jones, we're going to start cleaning now. I'm going to roll your blanket up to about your waist. This is going to expose you. Please let me know if you're uncomfortable in any way. So I'll roll the blanket up, and on the way I'm going to try to get that gown rolled inside the blanket so that exposes only the peri area. I'll cover her upper legs with a towel, and then get my first washcloth. I'm going to wring this out and soak 5 corners. 1, 2, 3, 4, 5. Okay, Miss Jones, I'm going to clean now. I'll use the heel of my hand at the top of her peri area and my index and middle finger to spread her slightly open so I can clean down the inside middle, top to bottom, and then we'll fold that leaf over. We're going to clean the outside labia, top to bottom, down one side, and fold that over. The third leaf will clean the other side of the labia, top to bottom, fold that leaf over. The fourth leaf is going to clean this area between the leg and the groin, this skin fold, top to bottom. We're going to fold that over, and we'll repeat it on this side, top to bottom. Now we'll place the washcloth back on the barrier. The second washcloth we're going to wring out, and we're going to rinse all of those areas the same way we washed. So we're going to hold her slightly open to clean down the middle, top to bottom. Fold that over. We're going to rinse down one side of the labia, top to bottom. Fold that over. Rinse the other side of the labia, top to bottom. Fold that over. We're going to rinse the skin fold down one side, top to bottom. Fold that over. And the other skin fold, top to bottom. We'll set that aside. Now we're going to dry all of those areas using short, soft strokes or a gentle pat. I'm going to unroll the blanket, which will place her gown back over her legs. Okay, Mrs. Jones, I'm going to scoot you toward me now, and we're going to roll you onto your left side so I can clean your back side. Go ahead and scoot toward me, and we're going to roll you over onto your left side. 1, 2, 3. The evaluator will hold the mannequin in place for you to complete your cleaning of the patient's backside. Okay, I'm going to take the fourth washcloth, wring it out really well, and we're going to soak 4 corners. 1, 2, 3, 4. I'm going to start at the anal opening and go up the center crease, right up the middle, and we'll fold that leaf over. The second leaf will clean one buttocks, We're going to fold that over. The third leaf will clean the other side of the buttocks. We'll fold that leaf over. And the fourth leaf will clean from the anal opening up the center crease one last time. We're going to set that aside. Whatever we wash, we rinse. So I'll wring that out. And I'm going to rinse the same way we washed. So from the anal opening up the center crease, fold that over. One buttocks, fold that over. The other side of the buttocks, fold that over. And once more up the center crease. And then we'll dry all of those areas. Okay, Ms. Jones, I'm going to change that pad out from under you so you're on a nice clean pad. We'll roll the soiled chucks toward the patient and tuck it under her hip. Unroll the clean chucks and tuck it under the soiled. Ms. Jones, come on back, please. And scoot to the middle. Thank you. Okay, Ms. Jones, go ahead and scoot toward me. And roll up on your right side. 1, 2, 3. Thank you. We'll remove the soiled chucks from the bed and unroll the clean. Okay. Go ahead and scoot back to the middle, please. This is going to be thrown away. Okay, Ms. Jones, I need to put all of my soiled items away and clean my basin. I'll be back in just a moment to get you situated. These items will go in dirty linen. And the basin is going to be cleaned the same way we clean everything else. We'll dump the water into the sink. Rinse the basin. Pick it up with a paper towel and dry the inside. We'll discard that paper towel. We'll dry the outside and discard that paper towel. And then we'll get the soap. I'll use the paper towel to open the drawer and store the basin back inside. These paper towels will now be thrown away. The barrier is going to be disposed of. And now I can remove my gloves. Okay, Ms. Jones, I'm now going to gather the privacy blanket up and pull your sheet back up. So I'll collect the privacy blanket by lifting from the bottom or underside of the blanket. I'm going to pull the sheet up and ball the blanket up into a ball. That way no trailing edges will contaminate other surfaces. Okay, Ms. Jones, let me go put this in dirty linen. Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay, here's your call light. If you should need anything at all, please let me know. I'm going to go open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections, and then let the evaluator know my skill is done. All right. Any questions?
I have a question.
Yes.
About the gown. Should you correct the gown or like in any way so it makes them more comfortable? Or...
Yeah, when you saw me roll the blanket up, I roll under. Okay. And when I do that, I'm actually grabbing the patient's gown as I'm rolling the blanket. So it's rolling up inside the blanket as I'm rolling the blanket up. So when I unroll the blanket, it spreads the gown right back out so the patient is covered without me having to touch that gown with my soiled gloves.
I have a question also about the gown. I seen underneath it the gown was wrinkled up and everything. Doesn't that also create bed sores?
Yeah, they're not really looking for that. It's not a tested checkpoint. And your patient in bed is going to bunch that gown up. We're just trying to minimize it wherever we can. Yeah, if you see it, then straighten it out. But it's not a graded checkpoint. And like I said, as they move, it's going to bunch. But you're thinking along those lines. I love that. I love that.
I know not on the test, but like in a clinical setting, whenever you have to roll them to their side, should you do the whole like the side
If they
procedure?
If they can't roll themselves, yes.
Okay.
If they can roll themselves, you just ask them, scoot toward me and roll on your
Okay.
side. We're going to let them do as much as they can for themselves because just remember I said your intestines, in order to digest food, need activity.
Yeah.
Right? So just that simple act of turning actually makes your tummy muscles work. So if somebody's stuck in bed, it's actually a good thing to get them to turn.
Okay.
It's healthy for them. Now, if they can't, they just had a huge incision right down the middle of their tummy. They aren't turning themselves. In that case, I would arm up, arm over, leg bent, leg angled, and turn them. Okay. So again, the answer is going to be, it depends. Depends on what your patient is,
Yeah, of course.
presenting to you. If you're ever in doubt, you should be able to talk to your nurse.
Okay.
Your nurse should be able to help you with that. Doesn't mean they're all good, but we're going to hope. All right, so let's go to page 79. I'm going to show you the second range of motion. We're going to go through the last range of motion in class on Monday. So I don't have any slides for this. I'm going to do this the old-fashioned way. I'm just going to talk it through. So how do we know what to do with each patient? So if we read the care plan at the top of page 79, it tells us to provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion extension. If you remember, flexion extension was up, down. Well, the elbow only moves in one direction. It only goes up, down. If you get an elbow to do anything other than this, you broke it. Okay, this is all an elbow will do. So flexion extension of the elbow just means we're going to go up, down, however many times care plan tells us to. And then flexion extension of the wrist is up, down, however many times the care plan tells us to. So let's look at the rest of the care plan. Provide 3 repetitions of each exercise. The resident is not able to help with the exercises. So this skill is knock, knock, knock. Hi, Miss Jones. I'm Patty, your CNA. I'm here to help you with some exercises. Is that okay? Close curtain, wash hands, elbow, up, down 3 times, wrist, up, down 3 times. Thank you very much, Miss Jones. Here's your call light. Is there anything else I can get for you while I'm here? Are you comfortable? Environment's clean. Bed's in low position. Open curtain, wash hands. My skill is done. That's the skill. That's it. The whole thing takes you way longer to do the opening and closing than it does to do the skill. So I'm going to show you what this looks like from beginning to end. I will simulate hand washing, but I'll show you what this looks like. I need a volunteer to come lay down in this bed for me. I'll leave that there for you guys to practice on later. Thank you. All right. So let me turn my camera around. Sorry, YouTube people, I don't have my automated thing going today. All right. Okay, here we go. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing all right. How are you?
I am fantastic. I need to do some exercises on your right arm. Is that okay?
I guess so.
Okay, I'm going to close your curtain. Let me go wash my hands and I'll be right back. I have clean hands. I have just washed my hands, however you want to say it. All right, Miss Jones, I'm going to do all the work. Remember, joints have to be supported, right? So I'm not just going to hold her arm up in midair and do something like this. Okay, joints have to be supported. All right, Miss Jones, I'm going to do all the work. All I need from you is to let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bend your arm up like you're making a muscle and back down to the bed. Remember, we always return to start. Always go all the way back down. So I'm going to turn your hand palm up. We're going to go up and all the way back down. That's 1. Feel okay? Up, all the way back down. That's 2. 1 more. Up, all the way back down. Feel good? Okay. Now we're going to move on to the wrist. I'm going to make a loose fist and we're going to go up and down like you're revving a motorcycle. Okay. So forward and back. Feel stretch. Feel okay? Forward and back. That's 2. 1 more. Forward and back. Good. Are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine before I go? That is in the low position and safe. I'm going to leave that there. But remember, our closing says our patient must be covered. if they're in bed. Is she covered? Okay. All right, Miss Jones. I'm just going to pull this sheet up. That way you're covered. There you go. All right, if you need anything at all, just use that call light, press the red button, and I'll be right back in. You're welcome. I'm going to open the curtain. I like my patients to look nice. I have washed my hands. I'll think about the steps of my skill and make any corrections. My skill is done. Okay? Yay! All right. We will do range of motion shoulder on Monday, which is just like what I just showed you, except it's on the shoulder. So range of motions are easy. That's why I told you I wasn't really worried about having to push those off. All right. Any other questions before we end class today? All right. I'm going to give you guys your review sheets for today's class. Those of you in YouTube world will be back on Monday. For you guys in the class, please remember that I do a CPR class Monday afternoon. So the room will not be available for practice on Monday afternoon. If you take the CPR class on Monday, it's $45. You don't have to pre-register. Just stay after class and I'll teach you. Go get lunch first. Because we'll be here a while. All right. YouTube world, we'll see you next time. Have a fantastic weekend. Until next time, happy caregiving. Bye.